Well, good morning, everybody. I'm Liam Donaldson, the Chair of the Integrated Care Board for the North East and North Cumbria. Welcome to our board meeting held in public. We haven't received any apologies for absence. David Stout, our Non-Executive Director and Chair of the Audit Committee, is attending virtually. And I'd like to welcome Sir Pally Hungin as a new Non-Executive Director to his first board meeting. We have a number of people in attendance publicly representing a range of organisations, so they're very welcome. And just confirm with our board secretary that we are quorate. And are there any declarations of interest for this meeting that are not already on your published and publicly available schedule of conflicts of interest? No, thank you very much indeed. Can we turn then first to the minutes of the previous board meeting, which was held on the 30th of January 2024. Are there any points of accuracy that anyone wants to raise? Thank you. So we confirm those minutes as an accurate record of the previous meeting. And then we have an action log on the actions that were agreed at the meeting, the last, and then followed up by the executive team. Are there any points anyone wants to raise in relation to those? Thank you. So we turn now to Sam Allen, our Chief Executive, to make her report.
Thank you very much, Salim, and good morning, everybody. So my report is included in the pack. I would just like to take us through a few items within the report, Chair. But I just want to start off just by saying that as we start to close our financial year, I'm very pleased that as the North East North Cumbria Integrated Care Board that we will deliver our plan this year within the available budget that was agreed with us by NHS England. Notwithstanding that, over the past year, we've faced some very significant challenges, as has the whole of the NHS. So we've seen ongoing industrial action, increased levels of need on our services and pressures on our budgets, not just budgets funding NHS services, but also our community and voluntary sector organisations. And inevitably, inflation nationally has contributed to a very complex operating environment. And having said that, we are also very mindful of the pressures that people living in our communities have faced over this past year with the cost of living increases. We have over the past year continued to make good progress to recover services from COVID, but certainly over the year ahead we will continue to focus our work on that recovery period, and particularly making ongoing strides to reduce the length of time people are waiting for their planned procedures. I'm really delighted to say that we have seen, I feel like we've turned a corner, and the corner we've turned on those elective procedures is where we have fewer people now waiting. So we went through a period this year where we continue to see the waiting list increase, and we do appear to have turned that corner now, which I think certainly bodes well for our ongoing recovery from COVID. Notwithstanding that, we have also continued to expand access in primary care. We've also, this past year, seen a marked improvement in ambulance response times, almost 12 minutes, which is excellent and certainly in some cases life-saving. And we've also made further inroads, particularly around early diagnosis of cancer and the treatment of cancer, although we have much more to do. And I just want to acknowledge Salim and the board, obviously our well wishes to the Princess of Wales with her early diagnosis of cancer, and it was no surprise that in the 24 hours after that the NHS website had an increase of nearly 350,000 additional hits and people seeking cancer information. And I think the message that she conveyed so publicly is, if people need support and help, please do access it. There's plenty of information available, and we also do want to encourage people to keep coming forward for tests. And indeed, this year we've also expanded our diagnostic programme. So our aim is the earlier identification of cancer for all, and really do want to encourage the public to seek that support should they need it. So notwithstanding all of that, this continues to be a busy period. We haven't quite finalised for our healthcare system our plan with NHS England yet, but like the other 41 integrated care boards, we have been submitting our plan, and you'll hear more about that through the course of the agenda today from our Finance Director David Chandler, and also indeed from Jacqueline Myers on the progress we've made through the performance, particularly against the key metrics that we've been very focused on over the past month, and they particularly include waiting times in the emergency department and cancer diagnosis. So Jacqueline will cover that in her update. Appended to my report today is our revised joint forward plan. So this is an expectation of NHS England for all integrated care boards. I do want to commend the team for the refreshed plan. This really is all about implementing our integrated care strategy, better health and wellbeing for all, and it includes some refreshed and updated sections, and I would ask the board to review that. What I would do want to really reiterate is there is no one part of this plan that any one part of our system can deliver on its own, and I was delighted to co-sign the forward for the plan with the chair of our provider collaborative, Ken Bremner, who, as you know, is a partner member of our board, particularly given the role of our foundation trusts, but also the partnership working with our 13 local authorities, particularly with our Healthier and Fairer programme through the plan. The one item that isn't covered in my report that I just want to make sure that colleagues are aware of is a very recently published consultation. This is on the government website, and it's for fluoridation, and there are proposals in there, Chair, for the expansion of fluoridation in the water in a number of areas in the North East and North Cumbria. Now, fluoridation has been a thing certainly since the 1960s, and I think several of our areas in the region are already covered, and indeed Hartlepool, whose water is supplied by Anglian Water, has been covered for some time, and I don't think it's a coincidence that we've seen some better outcomes there, particularly when it comes to dental health, and particularly for children and young people. So again, I would just commend the board and also for public awareness that this consultation is now live and there is the opportunity for feedback. But we hope with some of the long-standing inequalities here in the North East that the proposal to put fluoridation into the water will be a key part of our strategy, and indeed the Office for Health Improvement and Disparity strategy for improving the dental and oral health of people who live in our region. And then one other area I just want to draw out of my report, Chair, and this will be an area of increasing focus particularly with the, and I'm delighted that this got parliamentary approval, the devolution deal for the North East, and that's the work around public sector reform and working with the new combined authority for the North East. We've jointly worked together on the areas through which we will focus on public sector reform, and indeed wanting to make sure that in the work of the combined authority that health in every policy is an approach. And again, this builds on the work in our joint forward plan through our Healthier and Fairer work programme, but also highlights particular areas for integrated delivery around work and health. And we are currently waiting the outcome of quite a significant bid that would bring resources into the region to enable us to target people needing support into employment and paid work through a focus on their health and well-being. Also the workforce, if we think about the health and care workforce, certainly in the region we cover, that's about 170,000 people. And in fact, just in the NHS, I was interested, having attended the Jacobson lecture that the Chief Executive of the NHS gave at Newcastle University on Thursday evening, to hear for myself that 1 in 24 people who live in England work with the NHS in some capacity. The opportunities that we have got both across the NHS and social care and the caring workforce are really significant. So again, working with the combined authority there. And then 2 other key areas, firstly around housing, health and care, and our housing strategy working together with our local authorities, and indeed housing organisations here in the North East keeps going from strength to strength, and we know the impact of good quality housing can have on people's health. And then just finally, the other area for focus around public sector reform will be how we can play our role in reducing the number of young people affected by child poverty. And I know, Chair, at one of our future boards, we will be joined by the author of the recent commission around child poverty across the North East. And the NHS, and particularly healthcare, does have a significant role to play there, working with our partners in how we can do that. And I think, just finally, on the public sector reform aspect, how we can work together as an anchor system with all of our partners. So whether that's supporting people into paid employment in our services, but also how we utilise all of our resources to benefit the region. So I'm sure, Chair, at some point in the future we'll be looking at our values and principles around procurement and where we can ensure that provided we have value for money, as much of our local our budget goes into local services as possible. And then just 2 other areas, Chair, I just want to pick up. Firstly, the staff survey. So everybody will know that the NHS has an annual staff survey, and the Integrated Care Board participated in the annual staff survey for the first time in the autumn of last year, and the results have now been reported. What I would say is I think it's a bit of a mixed picture. So one of the areas I'm really pleased and proud of is that people in our organisation feel safe and confident to speak up. So culturally, it feels like we are on the right track there. Having said that, I think we've definitely got some tailwinds of the reorganisation and moving from 8 clinical commissioning groups into 1 new organisation, the level of turbulence, disruption and change for staff. And indeed, at the end of this month, we will conclude what has been our second in our short life already as an Integrated Care Board, significant restructure, and the whole organisation has gone through that. So we're working hard to work together with our colleagues right across the organisation to together work on the areas that we can. And during the month of April, we've got 3 all-staff events, and this will be the main topic of focus, because of course it is the people that define the culture in the organisation, not the organisation. The organisation is a construct of the people that make it up. So working together with people in the Integrated Care Board will be how we see continuous improvement in those staff survey results. And then just finally, delighted in my paper to cover the ongoing work of our learning and improvement community, Boost, which again is going from strength to strength. We've got just under 7,000 members now. We've Boost have set up a number of communities of practice. This, of course, was the one area across our integrated care system that all of our partners said we could do better on, which is how we share our learning, how we work together. We're also doing quite a significant amount of peer review work through Boost, more recently through the maternity services, where we've undertaken peer reviews of all of our maternity services and working together through our local maternity and neonatal network, developed improvement plans. Our housing strategy has just set up a community practice, and we've also just set a community of practice up on leadership. And Boost is open to join from not just people working in the health and care system or any of our partner organisations in the integrated care system, but also members of the public, patients, people with a lived experience, play a very significant role in how we're shaping up our approach to improvement across the integrated care system. My report covers a number of other areas, Chair, but I'll take those as read and happy to take questions.
Thank you, Sam. Just before opening it up, I'd just like to also reinforce the importance of the consultation on fluoridation. Fluoride is a natural component of drinking water around the world in many places, but by adjusting its level, you can bring the dental health benefits, oral health benefits to millions and millions of children. So it's been described as one of the 10 most important public health interventions in human history, including on the list smoking, physical activity, vaccinations, and fluoride is right up there in its potential to be transformative. And in this part of the world, to be able to see children growing up without the pain and disfigurement, the time lost from school, difficulties in accessing services, all of that will be immediately affected by and the benefit brought in health inequalities, as Sam's mentioned. So I do hope that you will have the opportunity to respond to the public consultation, but we're very excited about the possibility of this going ahead, and has been many times in the past proposed, but for one reason or another, legislative mainly, it hasn't been able to go forward. So thank you very much. Opening up now to Sam's report and any questions or comments on it. Kath McAvoy-Carr.
Thank you. Just two very quick questions, really. One is about the forward plan and whether or not there will be any more public-facing document that will help, a plan on a page. I know that's very difficult, but, or any involvement of children and young people in understanding that plan. And the second is about the staff survey and whether or not there's any learning across any of the other organisations that are intrinsically linked with the ICB work, and if there's anything that we can do to help support any of the learning from the staff survey.
Yeah, thank you, Kath. I'll just take those 2 points if that's okay, Chair. So just in terms of the joint forward plan and our overall integrated care strategy, we do have a plan on the page. And in fact, we worked with people first. And so we also have an easy read version of that. So we will update that, Kath. And of course, our child and wellbeing network, they have contributed to it, and we can have a think also about if there are any other ways of making it kind of accessible, drawing on their skills. Just in terms of the staff survey, so obviously all NHS organisations participated in that, and we have worked with the Provider Collaborative, and who I know are also looking at themes across the Foundation Trust, and I think they would probably summarise the year as it's been a challenging year with some mixed results. And so we've got some organisations that have had actual improvements across the 7 domains in the staff survey, and we have some that have deteriorated. And I think the ones that have deteriorated, there is triangulation with other aspects that we've been focusing on around quality. For example, Newcastle hospitals. I think the one area, if you look across all of the staff survey results, and this, I think we could look at whether there's wider learning across the sector. One area for me, which was a theme that came out, was flexible working. So we could do more to consistently offer flexible working opportunities, and that was a particular domain that whilst it wasn't sort of low as a national outlier, it was a sort of a standout one as one area we could improve, and I think we could work with all of our partners to think about actually how they're doing that and what we can learn from that.
Thank you. Dave Gallagher.
Yeah, thank you, Chair. It was just to add on the fluoridation consultation, encourage everybody to respond as individuals, but we've been consulted as an organisation as well, so we'll coordinate a response on behalf of the board. And a reminder to colleagues, we actually discussed it at the last board meeting, but we'll circulate all of the information, provide the links. Thank you.
Thank you. John Rush, Non-Executive Director.
Thank you. Just in terms of the partnership work that you mentioned, Sam, and it's great to see the links to the Tees Valley and the North East Mayoral organisation and their combined authority. Just a couple of things. One, I know you mentioned the child poverty. It would be really good to see at future meetings some examples that are being created or where there are some results early on about what they'll do. And also as well, and if we say that the local authority makeup is not of our choosing, but how do those things get reflected that we're doing or potentially in partnership within North Cumbria, which is outside the jurisdiction of those two authorities?
Yeah, thank you, John. And we'll definitely keep the board updated on the public sector reform work by combined authority. And as you quite rightly said, there are two combined authorities here in the North East. There isn't a combined authority, obviously, in Cumbria, but we do work closely with Cumberland Council and also Barrow Inverness. And we do have a health summit planned in Cumbria, working with the council and also all health partners. I think we've got a really well-established place committee also in Cumbria, so we've got strong relationships and a strong interface. I think, though, if I could just draw on the example of Boost through the learning and improvement community, the real opportunity we've got, though, through Boost is how we share the learning across the North East, North Cumbria. So whilst the mayoral combined authority may not be of significant relevance because it's a structural process for decision making and also a devolution arrangement, the work that it does, I'm sure Cumbria and lots of other areas will be looking at to learn from, and vice versa. And Boost for us will be an enabler of how we support that.
Thank you. Rajesh Nadkarni, partner member of the board.
Thank you, Chair, and thank you, Sam. I mean, first thing is to say that the work which is happening on dentistry is to be commended, because clearly the pressures, I mean, we've talked about fluoridation, but the initial actions which you all have taken, I think will make some short-term impact, so thanks for that. At some stage, I suppose the dental recovery plan will come back here for us to have a look at how we can have some of those changes on a more sustainable basis. So that was the first thing. The second point I wanted to raise was with regards to the primary care pressures. So it might be picked up in another agenda, maybe on the recovery plan, on how we actually moving forward to the engagement piece. But the specific question was about the shared care arrangements for certain conditions, which is putting a degree of pressure, which is highlighted in the paper. And any updates at this stage about what might be happening, about how we're going to take that forward, which is made reference to in the paper.
Thank you for comments on dental, and we'll absolutely bring back an update on the dental recovery plan, Rajesh, and Dave will be able to update on the work we're doing around shared care arrangements.
Yeah, so there's lots of conversation about shared care arrangements, lots of pressure. Because it's a huge topic, Rajesh, what we're looking to do is actually to bite it off in bite-sized chunks and look at the main priority areas. So the three priority areas that we're going to focus on, we're going to use existing mechanisms rather than set something up new. So we're having conversations about those three priority areas, which will get everybody involved that needs to be involved. Because it's not a primary care issue, it's not an acute care issue. By definition, it's the interface in the middle, so we're working on that.
Thank you. Supali Hungin, Non-Executive Director of the Board.
Thank you. Thank you very much for the long-term plan, Sam. Very much appreciated. Section 5 is on personal or personalised care. And this is an area which is important for me. And specifically in Section 534, we say joined-up clinical care. More generally, we know that many people experience just disjointed clinical care, but we all have experience of that in our friends and relatives. We recognize the long-term challenge to improve clinical coordination of care and communication, etc. Do we as an ICB have a working group or a specific plan on how we are going to improve clinical integration, which again is mentioned further down in the plan, together with earlier diagnosis? Do we have any strategy for rolling this out? I'm aware that many of the topics in this paper are top-line topics more akin to public health, but this is more to do with individual care. what can we do about this, or or is this something that we recognize but we don't have a specific plan for?
Thank you, Pally. I think it's a great question. It really is a great question, and we've got work underway on our clinical strategic plan at the moment, but that's a very condition focused. I think your question, if I've heard rightly, is more around the integration, but also the personalised aspect. We do have work underway around personal health budgets, but I think we've probably got more work to do to connect our clinical strategic plan with the various strands of work that we've got around personalised care and also personalised health budgets. So I would put it under the banner of more to do, and perhaps what we could do is maybe bring an update through to the next board meeting on this.
Just very quickly, if I 2 seconds flat. I mean, I'm speaking about integration between specialists in the same acute setting, between primary and secondary care, so that the patient journey is a short one, effective one, and a holistic one, rather than one which is truncated, confused, and involve many providers and clinicians of different sorts.
Yeah, absolutely. And I know the boost session we've got at the beginning of April that you'll kindly also come into some reflections where we'd be listening to the journey that the NUCA system in Alaska has done on this, I think will be helpful to us. But I think also with our local delivery teams, so our 6 new local delivery teams, their whole core focus is going to be on out-of-hospital care, integration of pathways. We'll have the real opportunity, I think, to move this on. But we do need to develop that within a framework so that from a system perspective, we've got an agreed strategy that people are signed up to. And I think we've got a bit of a gap on that at the moment, Pally.
Thank you very much. Graham Evans.
Thanks, Chairman. Just to respond to Sir Pally's question, last month we presented the Digital Data and Technology Strategy to the board, which was approved. But within that, we talk about how we integrate our healthcare settings using technology such as the Great North Care Record between points of care. So that's one element which will contribute. It's not the be-all and end-all, but also how we put citizens more in control of their own health and care using technology such as the NHS app. That will help put people in a bit more, a bit more of a positive situation in that respect.
Thank you. We do have to keep an eye on time. We're moving into a long agenda. But I would like to ask one question about GP primary care access that you may not be able to answer now. And it's based really purely anecdotally. I prefer to call it soft intelligence, but a number of conversations I've had around the country in the last few months, I'm picking up that some primary care services, general practices, are subcontracting the initial contact with the practice to agencies or groupings. So ineffectively, somebody else triages before the patient arrives in general practice. And certainly the anecdotes I picked up from generally older people were very unhappy about this because they felt it was already difficult enough to get through, to get a face-to-face appointment with a GP and then to be told, well, this is only the first stage. And I just wondered whether this is happening in the North East and North Cumbria.
Not as far as I'm aware, Salim, we have trained care navigators, but they sit in practices as part of practice staff. But I know Neil would want to come in on this as well.
Yes, thanks. I don't think there are any examples where it's being outsourced. There are some examples in the north where a number of practices have come together and almost as part of their grouping arrangements, then the initial contact with the practice is taken at a central source, and then appointments will be made within all of their individual practices. But that's one of the very large practices up in Northumberland. I think there's a lot of innovation going around in general practice at the moment, and I think trying to harness sort of that innovation and take the best of it, and really weaving in the public's expectation and thoughts around how you access your primary care service, and also bringing in Pally's comment around the importance of continuity of care is something that we are going to have to build into our stabilisation plans for general practice over the next few years.
Fine, thank you very much. As long as we don't inadvertently invent innovative barriers to access, that's the main thing, I think. Okay, we move on to a few governance items, I think, which are very important. And Claire Riley is going to take us through them, starting with amendments to the Governance Handbook.
Thank you, Chairman. Board should be more than familiar with the Governance Handbook. This is version 8, so we would have seen it 8 times now. I'd like to draw your attention to changes highlighted to the scheme of reservation and delegation. The handbook also reflects on an annual review of the committee terms of reference, and the reviews have gone through the committees. What I will do is caveat one committee, which is Finance, Performance and Investment. Changes had been made and had been ratified at that committee. However, further changes have been subsequently made. Therefore, my request to Board today is to approve that amend, subject to ratification at the next Finance, Performance and Investment Committee. This handbook also updates the ICB committee structure. It updates the position re the subcommittees. Therefore, I ask the Board to approve the scheme of delegation, the terms of reference for the committees, the updated committee structures, the updated governance handbook, and the inclusion of the updated subcommittees terms of reference as listed within the governance handbook. I'm happy to answer any questions, Chairman.
Okay. Are there any questions about what's planned, and are people happy to agree to the changes? Right, I can see nobody wanting to intervene, so those changes are agreed. Claire, now moving on to the Constitution for the next agenda item 8.2.
Thank you, Chairman. Again, Board should be more than familiar with our Constitution. In front of you is an updated Constitution. The summary of the changes are detailed within the summary report. We can confirm that the changes recommended are fully compliant with NHS England requirements, and the changes now align to the changes that have been made as a result of ICB 2.0 and the changes to the operating model. This also reflects the portfolio changes that come in within the executive directors that come into effect on the 1st of April. The Board are therefore asked to approve the amendments set out in the summary and agree for the Constitution to be submitted to NHS England for approval.
Any questions or clarification on that? So you're happy to approve? Good, thank you very much indeed. And
standards of business. Yeah. Thank you, Chairman. Again, the Board should be more than familiar with the standards of business conduct and declarations of interest policy. You would have seen this on numerous occasions. The policy has been reviewed in light of changes as a result of the ICB operating model, and the summary of the changes are detailed within the highlight report, which is the first page. I ask the Board to review and approve the policy in front of you.
right, similarly, are there any questions or clarifications required? I don't see any, so we're happy to approve that as well. Thank you. Coming then to the Board's committees and the report on their business, starting with the Executive Committee, which is chaired by our Chief Executive.
Thank you, Chair. The papers include the decision log for 2 meetings, our January meeting and our February meeting. There were no items for decision to highlight for our February meeting. There were 3 key decisions in our January meeting, one relating to primary care, dental access recovery plan, another the protected learning time proposal for general practice, and then finally the Armed Forces Reserves and Cadet Policy, which we approved, Chair. I'm happy to take any questions on either of those items.
Any questions or comments? Dave Gallagher.
Yeah, thank you, Chair. And just on the Armed Forces Reserve and Cadets policy, as a result of that and other work that we've been undertaking, I can confirm to the board now that the ICB is recognised as a gold level employee recognition as part of the MOD work, which is a really good thing to do. We thought we were going to have to go back to scratch, but we've built on the legacy from the CCGs and enhanced that. So I think it sends out a good message in terms of our support, especially given the large numbers of people from the North East and North Cumbria who contribute to the armed forces.
Okay, thank you very much. Moving on to the Quality and Safety Committee, the last meeting was on the 11th of January. Eileen Kano, Non-Executive Director, chaired that committee meeting.
Thanks, Elaine. The last meeting was in March, and that was chaired by Hannah Bowes as vice. We have the minutes here approved by the committee for information for the board, but I'll hand on to Hannah to give highlights from the recent meeting in March.
Thank you. So this is just a brief update. Obviously, 4 minutes will follow, and you should have those by the next board. But you can see on the slide that's been produced here by Neil. Thank you very much, Neil O'Brien. It gives an overview of the key things that we looked at in our recent meeting. As always, we had a patient story. We do this in every meeting to try and kind of ground us really in the experiences of the patient, which is obviously our central focus in the Quality and Safety Committee. We actually had 3 different accounts this time, so it wasn't just a single patient, different perspectives of engaging with children's mental health services and their reflections of those services in our region. We then had various reports, you can see here these related primarily to our continuing healthcare, healthcare associated infections across our trusts, Coroner's Regulation 28, so various reports in relation to preventing future deaths, our learning from lives and deaths, people with learning disabilities and autistic people reviews. We also looked at the clinical strategy and clinical effectiveness subcommittee terms of reference, and a discussion was had about those and various kind of points were raised which are going to be taken back, so we expect to see those at the next board. And we also had several presentations, one of which was around the continuing healthcare, which is a recurrent topic, of course, at our Quality and Safety Committee. So as I said, 4 minutes to follow, but if anybody has any questions now about what we discussed at that meeting, I'm happy to do my best to take them.
Just on the healthcare infection, it's something that we haven't had on the main board agenda as a topic, and yet it's always said that it's probably the most obvious first aspect of safety that you would look at, and has always been. So I'm just wondering if, I mean, first of all, if you have a recollection of the extent to which our performance is comparative to other parts of the country, and then within the ICS area, what variability there is. Is there anything that you could...
So we're out of trajectory for all of the main infection control, C. diff particularly. So there is a formal plan for the ICS in terms of standardised process. We've done peer review visits looking at the process that people take in terms of deep cleaning, hand washing. So there's a full paper on this. We also have had one organisation that's had a large number of MRSA bacteremias that we are doing serious incident reviews on all of those to look at theming those so that we get the learning. And then there's some specific infectious difficulties in one trust as well around CPE. And they've changed their model of operating to look at how they check patients prior to entry. We're very happy to come and do some more full discussion at a different board.
Want to add anything, Hannah?
Just to say that if you look at the minutes which are in the pack from the previous meeting, the sort of update that we had at this meeting was largely building on that with similar sorts of themes really in relation to what David's just outlined there. So I mean it's a recurring issue and one that we're discussing at each Quality and Safety Committee at the moment.
I mean it's one of the one of the areas of healthcare where the evidence base is really very, very clear. And then there are some innovations coming in, for example, the use of fecal transplantation, which isn't as invasive as it sounds, for Clostridium difficile, which has been transformative in some parts of the world. So would you, just before coming over to Eileen, would you be supportive of an agenda item on healthcare infection, just so you can see where we are and what more could be done? Okay. Eileen.
Perhaps just the last point. Firstly, to commend Chris Piercy, who's been doing a lot of work in this area, bringing together providers around healthcare infection. One of the, I suppose, sort of structural challenges here is decant facilities. So the ability to be able to do deep cleaning, and I think that's an estates matter. So I think it would be a really good idea to bring this. I think we've seen the indicators looking not great for a while. Yeah. There are lots of actions, but we need to do something to move the dial. And I think looking at innovations, but also looking at the structural things that we can do to try and address this.
Off the cuff, David, can you remember what our compliance with hand hygiene is overall?
Very variable across the patch. But very variable across organisations as well. So some places really excellent, some as low as 50%.
Okay, thank you. Any other questions on this committee's work? Thank you. We're now on to the Finance, Performance and Investment Committee, and that's chaired by John Rush, Non-Executive Director.
Thank you, Chair. Just in terms of the minutes that you have before you, they're from the two meetings on 7th of December and the 1st of February. I mean, we tend to cover the same things because we get the performance update and the finance update, but also as well going through some of Sam's report earlier on, some of those things in terms of performance are also noted, and I'll come on to the actual meeting that we had in March, which you haven't got the minutes for, but just to give you some of the latest information on that, is that we obviously received the update on the development of the 2024-25 financial and operational plans, and I know that David's going to speak later on about a little bit more to do with that. But as we become more and more of a assurance and a scrutiny committee, which again touches on the slight time it's taken us to do the terms of reference, because we need to kind of cross-reference those to what's going on in the executive committee. We do get in that position where we are reviewing obviously the system finances, but we were very keen to know the fact that we are on plan at the March meeting for the deficit and the surplus budgets that we agreed for our overall plan for the ICS. There was discussion over electric recovery funding, and we made a recommendation again, which David will touch on, back to the executive in relation to their delegated responsibilities for allocations of money, etc. So we were involved in that process as a committee. And as we are linking more and more in with other partnership parts of the ICS, the capital arrangements that are being put in place via the Infrastructure Board were discussed at earlier meetings, but also again discussed in March, and we made arrangements for the chair of the Infrastructure Board, which is James Duncan, who is actually the Chief Executive for Cumbria, Northumbria, Tyne and Wear, who chairs that particular group, to explain to us how that we were going to receive reports on behalf of the ICB from that provider kind of relationship. So that was very useful in terms of building those relationships, and again, talking about us as a group which is going to do more scrutiny and more assurance rather than actual decision making. So that was good. And in relation to performance, I know that Jacqueline will mention later on when it comes to the performance side of things, the information that we had about health inequalities, which was a sort of relatively new addition to the report, which was very well received, and it gives a more accurate assessment of some of the reductions or increases in inequality across the area. So that was a very, very important piece of work, and I think, as I say, Jacqueline will talk about that later on. And just in terms of performance overall, still concerns for us mental health. We discussed in the private part of the meeting in relation to getting the right data and how we're going to work on that as we go forward into 24-25. But obviously some concern over waiting times. We've talked about dental. Again, that was touched on very heavily in Sam's report, but access to dental services still remain a concern, so we note that. But we also note as well the recent upturn in elective long waits for the 78 weeks and 65 weeks, which again is quite important. Then finally, from that point of view of assurance and understanding what's going on, we noted the oversight arrangements in place to support the various providers in our area, particularly the work that Jacqueline does on behalf of the ICB in terms of that support for them and also the relevant challenge as well, where things aren't going so well. So we note that, and I think that's a very important part of what we're doing and trying to achieve as ICB in relation to that supportive, collaborative work that we're all in this together. So they were probably the main highlights from the March meeting.
Thank you, John. Are there any comments or questions anyone would like to raise with John? Okay, thank you very much indeed. We are a little bit ahead of our time. Sorry, Hannah.
It's not to follow up to John's point, but just a correction on mine that it was Neil Hawkins, not Neil O'Brien, who produced the slide. So apologies to Neil Hawkins.
Okay, we're ready to move to the performance integrated delivery report if we feel we can fit it in before our break, which I think we probably can. So, Jacqueline, over to you.
Sorry, we do have some slides. Is there a clicker available? Oh, is it now? Oh, I've seen it. And here it is, just by magic. Okay. All right, thank you, Chair. I'll just bring my mic a bit closer. So, as Sam mentioned in our Chief Exec report, we're going to take the opportunity to give a bit of a forecast around small basket of the performance metrics that NHS England asked us to have a particular focus on improved delivery during the month of March. Obviously, it's the 27th today, so I never want to count my chickens, as it were, but I think we can give a fairly clear steer on these particular metrics. So firstly, in relation to urgent emergency care, there were two asks. Back in sort of October, November time, when we did a revised so-called H2, so second half of the year replanning process, we did post a revised plan month by month for the category 2 response time as an average across each month, and at that time we aimed to deliver a 27-minute and 5-second performance during the month of March, and the ask from NHS England was to get on and deliver that. I have to tell you that unfortunately we're unlikely to deliver that given where we are on the Cat 2 performance in March. We're currently, or at the last measure, we're running at 31 minutes and 36 seconds. So, you know, considerably over the forecast done back in October. I suppose the bit of good news is it isn't an improvement on last month, but a 2-minute improvement on the performance we delivered in February. The second ask was to deliver the 76% performance in A&E 4-hour standard. You remember that was the national ask in the planning guidance for 23-24. As at yesterday, the month-to-date position across the whole of the NENC provider system was 75.4, so perilously close, but with only 5 days left. I think on balance it's unlikely that this will be met. But again, it's an improvement on the February position, which was 74.1, and we're still, as I'll explain when I go into the detailed report, benchmarking relatively well on this. So this one isn't impossible. We actually on Sunday delivered nearly 78%, and if we did that for the remaining 5 days, we would just squeak it. But I think, given the turbulence in the system and what I saw around yesterday's performance, I think on balance we're just going to miss this one. In terms of elective waiting times, board's aware because we have reported a number of times that in recognition of all the industrial action and other pressures in the system, again, during the replanning exercise back in October, we submitted revised trajectories for both over 78-week waiters, and so our overall North East North Cumbria target became 167 for over 78-week waiters, and 1,145 for 65-week waiters. So here we have some really good news, I think, in that we're looking almost certain, I'll say, to do better than our 78-week plan. So as at last Sunday, we get fresh data in the middle of the week. the actual number of patients waiting in the system over 78 weeks had fallen to 116, and actually there are only 28 patients of those who are forecast to be over 78 weeks by the end of March who didn't have a so-called come-in date, so a defined date. So unless things go horribly wrong, I think we can be confident. We actually did a forecasting exercise with all of our providers a couple of weeks ago, and their forecast was 40, again 78 weeks for the end of the month, although I think we may do even better than that. In terms of the 65-week performance, again, I'm now saying it's highly likely that we'll do better than our plan. As at 9 days ago, there were 1,261 patients waiting, but only 1,055 of those needing to be treated by the end of March, who again didn't have a date to come in, and I expect we'll see even further improvement on that. So again, I think we'll exceed our plan of 1145. And then finally, there was an ask around cancer waiting times. You'll remember that the main measure this year was around reducing the number of people who've been waiting over 62 days to either get a diagnosis that's benign and get discharged or get their first definitive treatment. And our plan was to get to no more than 817 in that backlog. And I'm pleased to say that as at last week, the backlog stood at 747, so we've already significantly reduced our backlog compared to the plan, and I'm also really pleased to report that all 8 of our trusts who are monitored against this target have fallen below their individual plan, which is a cracking achievement, and real significant progress delivered in Q4, because we started Q4 quite a long way north of our plan, so really great to see. So that's just a quick update in terms of the priority March asks, and then I'll very briefly draw out a few more headlines, Chair, if I may, and then just comment on the new inequality section in the report. So in terms of urgent emergency care, won't labour this because obviously you've had a more up-to-date position, but in terms of the formal reported data for category 2, so this is the requirement nationally to have a 30-minute average across the year, and then we're monitored in month. I think I mentioned already that in February we closed out at 33 minutes and 31 seconds. So actually a slight deterioration in the rankings compared to January.
Jacqueline, sorry to interrupt. These are very interesting presentations. Could I just ask you to, because some members won't be familiar with quality improvement run charts, and we'll see some dots high and some low and some in between the two lines. Would you just, when you are going through the different topics, point out the ones which give either concern or particular reassurance on that way of looking at the data?
I'll do that, thanks, Chair. I think we've previously discussed in the board how these SPC charts monitor whether if you like, a measure is in or out of control, and if we are seeing it in control, whether we've seen a step change, deterioration or improvement as defined by the number of blue dots, which are a positive trend, or the orangey red dots, which are a negative trend against the, if you like, standard that we're trying to achieve. So when you look at this category 2 response time here, you can see we've had quite a turbulent time. We did have a statistically significant deterioration in performance over the winter months as defined by those weekly measures that we take. We're seeing some improvement, but it's not yet what we describe as sustainable based on the data that we've got here. I think this is an interesting one in the sense that we could also measure it daily. But in terms of these weekly measures, this is, if you like, a standard that's not yet in control and delivering sustainably. We're seeing some green shoots in terms of improvement, but we've not got it sustainably delivering in that against that target of 30 minutes. I think I've commented otherwise in terms of what we've seen in relation to this. Sam mentioned earlier that when we look at the whole year performance, I think we will then be able to see a sustainable change, because across the whole of 22-23, the average was over 45 minutes, whereas across the year for 23-24 we'll be looking at around the sort of 34-35 minutes, so a really significant improvement on those longer time frames. Below that, you've got a measure of ambulance handover times, and you can see that that really has gone through a significant period of deterioration across the winter, and not yet back under control. So just 3 dots there, if you can see below the line. Obviously, if we sustain that for another 5 weeks, we'll be able to say that we've got a sustainable improvement. In terms of the current position, we're around 3 minutes above the plan that we set ourselves. So of concern there, huge amount of work gone into trying to deliver more sustainable ambulance handover times, but I think that lack of a sustainable performance is certainly what's reflected on the ground. I was on call myself this weekend and certainly experienced some ambulance handover delays regrettably, and there's more work to do to hold this in a sustainable position, but an important measure for us because of its concomitant knock-on to ambulance response times. Just in terms of the A&E 4-hour standard February performance, you'll see there that the position was 74.1 I mentioned earlier. What we've seen, as you can see from the graph here, is we've seen a movement away from our plan. So we had a plan this year that saw performance get better successively over the months coming out of December. And although we have improved, it's been at a slower rate than we planned. So some concern there. Again, in terms of benchmarking, as an ICB, we're 10th out of 42, so in the kind of upper quartile of performance, but still lots of work to do in terms of improving this performance. And an associated measure that we like to keep an eye on is 12-hour delays from a decision to admit in an A&E department to the time it takes for those relevant patients to get into beds. And you can see it's still a matter of concern here. Just to remind the board that prior to COVID, these were very rare events, 12-hour delays in department, and you can still see we've got really significant numbers of delays occurring. Just to move to the elective position, I think this kind of paints the picture I've just been reporting on, that we really have seen a really pleasing improvement in the position in recent weeks, because when you look back at where we were a few weeks ago, it did look like we had a real challenge to get back on plan. And so what you're looking at on the graph here is the various plans that we've had over the course of the year. So the original plan, and then the revised plan is the grey line, and the yellow plan is a sort of the yellow is what we call the PT. It's the kind of forecast do nothing in terms of the trend that's going on. So originally we sought to get to 0, as you know, on 78-week weights, and we then had a revised plan of 167, and you can see that as at these data, we were still a distance off. I guess I've given an update on this, Chair, so I probably don't need to go into this in any further detail. There's a little bit of information further down here in terms of the specific trusts who are driving the ongoing 65-week weights. So it's particularly around our 2 tertiary centres, Newcastle and South Tees, with smaller numbers in South Tyneside and Sunderland and North Cumbria. I mentioned when we did the plan presentation earlier, though, that we're pleased to say that in the draft plans, all of these trusts are looking to eliminate their 65-week waiters by the end of September this year. And then in terms of the cancer position, I think, again, we've covered this with the March update. So really pleasing to see that we've crossed the line and got below the March position, a couple of weeks ahead of the deadline. Just wanted to draw out of this slide the position in relation to 6-week wait. So this is the requirement in the long-term plan that by March 25 we return to 95% of patients getting a routine diagnostic being seen within 6 weeks. And there really is no, perhaps we should SPC this chart, there really is very little discernible improvement over a 12-month period here. It's pretty flat. So in January, which is the latest data we've got, it's 18.6% of people waiting over 6 weeks, so quite a long distance from the 5% max that we want to get to in a year's time. And you'll note in the key points that there's really significant difference between our providers, with the best already achieving below 5% at 3.3, but our most challenged trusts at 32.9. So in terms of actions, we've asked our mutual aid group, which was originally set up to look at elective mutual aid in terms of treatments, to also start to address some of these diagnostic challenges. Underneath the data, there are 15 key tests that are measured, and there are a couple that are pretty much challenged everywhere, notably non-obstetric ultrasound. But for us, we are looking for opportunities to level out some of those variations between providers. And then lastly, I've just got a pack of slides where you can see that we still really are struggling to get on top of the mental health waiting times in all of the 4 categories that we measure, Chair. So you can see there growing numbers of patients and growing lengths of wait on our key mental health waiting lists. I mentioned earlier during the plan presentation that we may, for the first time, get some national measures in terms of the length of wait. So real concern here. So I'm just going to let you look at the trends. So this is children and young people who are waiting and have had less than 2 care contacts. This is children and young people, but on the autism and neurodevelopmental waiting list, so really significant growth there. And then these are the 2 adult charts. So this is adults. For some reason, the measure is slightly different. We measure those who've yet to be brought in for a single care contact. And then finally, this is the adults waiting list for autism and neurodevelopmental. So just an escalating level of waits across all of those services, and clearly the work that we've done to date in terms of recovery plans have not started to bite. I think we can see that activity is rising, but waits are rising at a faster rate, so a much more wide-ranging recovery plan needed. Lastly, I just want to touch on out-of-area placement bed days, where they're not clinically indicated, and there is some good news here in terms of the numbers falling, and I want to particularly note that CNTW, one of our 2 providers, has managed to maintain 0 out-of-area inappropriate placements since October. We've also seen improvement in TÜV. They have 5 patients out of area at the moment, which are driving these levels of out of area bed days. But again, just connecting this back to the earlier plan presentation, CNCW have posted a draft plan to maintain their position, and TÜV have posted a draft plan to eliminate their remaining out of area placements. So good to see some progress here. That just concludes the headlines. Finally, I was just going to comment on the new inequalities section that we've developed in the IDR report this month. I think this is a work in progress, but there's a wealth of information, particularly in Appendix 2, so if people haven't had a chance and want to have a look, not just at the data, but also as we're starting to gather the action plans against them, I think that's kind of really useful to see. So I think there are some reassuring data in the report that we can start to hopefully draw some causation between the actions we're taking in our Healthier and Fairer programme, which, to remind the board, addresses both our prevention agenda and our reducing inequalities agenda, but we can also see a fair amount of work to do. These data don't move massively from month to month, so the plan is to bring this report twice yearly to the board. And I think looking at the way that we've structured it for the first time, there's an opportunity to bring the future report more in line with the performance report, where you're getting that detailed report against the data and the actions in the main body of the report. So I'll look to do that for the future. I'm happy to take any questions. Thank you.
Thank you very much indeed, Jacqueline. So comments and questions. Christopher Ackers-Belcher, representing Health Watch.
Thank you, Chair. It was just in relation to the children and young people's waiting times for mental health, because in the report it says 10.1% waiting over 2 years, and it also says that there's some work being done, transformation work, for the Mental Health and Learning Disability Subcommittee. I'm just wondering whether or not that can be shared, like what that work is. But on page 11 it says that the trend is it's improving, but on page 6 it says it's worsening, and I just wanted clarification on that.
So I believe that in terms of the over 104 weeks specifically, that position is static or improving, but the overall size of the waiting list is growing. So apologies if the clarity in the report needs looking at. I'll have a look at that, Christopher, and make sure that we're clearer. I think it would be really helpful to get a national set of measures that we can comply with in terms of the way that the waiting list time intervals are measured, but I'll make sure the report is clearer in the future. Thanks.
Chair, can I just come back on one other point? Yeah. It's just also on page 11, it has people with learning disability and autistic people. The target's 75% for their annual health checks, but we're running at 39.3%. And bearing in mind, I think we've raised it before, the correlation of early mortality for people with learning disability and autism, and just whether or not there's more work that will come back to this committee to share what we're doing in order to increase the health checks.
Thank you, Jacqueline.
Yeah, just briefly on that latter point, we did have a look at the data last year, and we did observe that there's a very busy period during Q4 when a lot of these checks seem to occur. So I note your concern. I think it would be helpful to look at the full year position and see where we get to there. I think we're just looking at data up to, I think it's November actually, so there's quite a bit to go, but recognise the point you're making, so we'll be sure to draw attention to that in the next report when we have the report where we have the full year of data. Thanks.
David Perdue.
Yeah, as it's following the Quality and Safety Committee in March, where we had the 3 young people who they said was kind of how can they be safe while waiting for their CAMHS referral. We're going to do some specific work around actually what can we do in terms of signposting those young people to other services that are available, and working with Neil's team in terms of primary care to look at actually what can we offer differently.
Thank you. Sir Pally Hungan.
Thanks for the report. I wondered if we have any data on transfers from one trust to another to help patients go to trusts where the waiting lists are shorter, and whether we as an ICB have a policy on this.
So we don't have a policy per se, but we do have a set of procedures that we've agreed under the Strategic Elective Care Board. We have a subgroup that focuses on mutual aid, chaired by one of our COOs. It's relatively early doors, so I think we're talking about dozens rather than hundreds of patients that have been moved around the system. I haven't got the exact data to hand, but happy to try and bring something to a future meeting if that's helpful.
Okay, we have got a number of other people, just to emphasise that we are taking them in the order you put your flags up, so don't worry. Won't overlook anybody. Saira Malik, partner member.
Thank you, Chair. Thank you, Jacqueline, for that very insightful and in-depth report, which I always find very useful to understand what's happening on the system. I just had a couple of questions. One was around healthcare-associated infections, which I know Sir Liam and David have already touched upon. But obviously we know things like C. difficile are dependent on kind of bed stays as well as antibiotic use. And I just wonder whether it might be time to revive kind of public-facing communications with regards to antibiotic overuse, which might help. And obviously I noticed at the bottom of your second slide you mentioned, you know, the criteria to reside, not meeting the criteria was 8%. So is there a potential for us to be causing harm for patients who don't need to be in hospital being in hospital, and just the public being aware of that? My second question was around the data that we hold on rate of tooth extractions due to decay in children's teeth. And obviously that's quite concerning because, as Pally referenced before, holistic health is very important, and our dental health plays a massive part in the trajectory of children to adult health as well. Are we doing any targeted work on kind of focusing specifically on children and kind of dental services needed for them?
Yeah.
I think probably you and David both want to comment. Go ahead.
Do you want to go first? Yeah. On the...
Just in terms of the IPC, Sarah, from a antimicrobial stewardship perspective, all the trusts are actually doing really well from that element. So we can bring that back in terms of the paper, in terms of the different elements of it. Just in terms of meeting the criteria to reside, so as a system, we're about 8.1% at the moment. There is mass variation in that, with one organisation particularly having major issues compared to others, but we perform comparatively excellently compared to the region and nationally in terms of that figure. But there are issues, and we do collect that in terms of harms when people have either developed infection when they should have gone home from that date, so we can share that information as well.
I was just going to comment, I mean, we do have very detailed data packs on the no criteria to reside, and we can bring some of that through. We've got overall, you know, better than comparable level to peers, but within that there's really significant variation, and North Cumbria would be the area where we've got most concerning, where we're north of 20%, and clearly that gives them a lot of challenge in their bed base in the hospital. So I think that's something that we're focusing on very much in our recovery plans. In relation to the paediatric tooth extractions, I mean, Dave may want to comment on this. I suppose, as we all know, that's at the end of a long chain, isn't it, of events. So I guess it's the dental access recovery plan and ensuring that children get timely access to dental care, as well as the, you know, in the very long term, the fluoridation work that we were talking about earlier. In terms of the more public health side of it, I haven't got any knowledge on anything specific that we're doing in relation to that, but certainly something we could find out, and Dave may want to comment.
Levi Buckley.
Thank you, Chair. Sorry, just to refer back to Christopher's points around children and young people's mental health. I think, Christopher, we all share your concerns. We've seen an almost doubling in referrals to mental health services from 2019 to the current year. That's not just locally, that reflects the national position. Just to give you some assurance in the short term, so we have invested some additional resources both with our acute providers on paediatric pathways, but also our mental health providers for some additional diagnostic work during February and March and into April to particularly tackle the longest waiters. As the forward board planner says, we'll be bringing a more detailed piece of work on the transformation to the May board of directors. And there's probably a kind of a twin track approach here. There's something about understanding what we can do about those longest waits and improving our diagnostic pathways. But probably as importantly is the maintenance and ongoing support for young children and young people when a need is first identified, whether through primary care, families, or more often through schools. So our approach will be a much more needs-based approach of getting people into the right support that keeps them stable, supports them in terms of inclusion at school and emotional regulation, whilst we do some further work on the transformation. And just as a final example there, next Friday, the 5th of April, we have a full system event in North Cumbria where we're looking at the Portsmouth model around neurodiversity, which was seen to triage circa 80% directly to support rather than on a diagnostic pathway. So just to confirm, Christopher, yeah, absolutely, you know, the one thing that keeps me awake at night is children and young people's mental health. But it's a really key part of our programme for the year ahead.
Thank you, Levi. Mike Smith, partner member.
Thank you for the report, Jacqueline. Firstly, the welcome arrival of the dental UDA metric. But I did note the caveat that it doesn't include the sessional work that we're incentivising as an ICB. I wonder if it would be helpful if at some point we could try and incorporate that so we can get a true view of what we're providing rather than the possibly more negative perspective of the UDAs, which makes it look worse than it really is. The second one was regarding the mental health weights. It's great to see this now fully incorporated into the report. And I appreciate it's been added in year, so this may already be in hand, but I wonder whether we should set some plans and targets for the year ahead so that we can make it very clear what we want people to do from a board perspective and what we're hoping to see. And then the final point is relating to a conversation we had in the Finance Subcommittee regarding the fact that in the health inequalities section, a lot of the work that needs to be done to improve those is longer term prevention, left shift kind of work. And it's not always evident to what extent we're spending the resource that we have on reactive care or preventative care. And it is very difficult to try try and separate them apart, but whether it would be useful to have a metric on what amount of our resource we're investing in prevention rather than reactive care, recognising the challenges that might bring.
Okay, thank you for those proposals. A very important area that you've highlighted, I think, for us to get into. Tom Hall, partner.
Yeah, thank you. And kind of building on Mike's comments, really, which I support, I just want to thank you for the section now included around health inequalities. I know it's something we had discussions on from the very genesis of the board, really, which is how do we shine a light on health inequalities and what we're doing about it, because as we know to a certain extent what gets measured gets done as well. So it was just to ask that we spend a bit more attention on this the next time the report comes, so we can have perhaps a more in-depth discussion as a board as to what's going on within that report and what we're doing to address it. I'd really welcome that if that's okay. Just to quickly pick up on Sarah's comments about oral health promotion as well, and work that takes place within schools around and wider into the community as well, around improving the oral health of children and young people on top of key initiatives like community water fluoridation. There are currently contracts that support oral health promotion that are held centrally by, I believe it's the ICB now, it used to be NHS England, but I presume those commissioning responsibilities transferred over. But there is reference within the dental recovery plan to enhance that, and I haven't seen the details of what that looks like yet, so that might be something we want to pick up.
Okay, thank you very much. And Dave Gallagher, I think, is the final comment.
Yeah, thank you, Chair. And just to pick up some of the dental oral health comments, Mike, in terms of the UDA approach and the metrics, absolutely. We're working hard to try and get something that really demonstrates the impact of the interventions that we're having, so we've got a fuller understanding of it. So we'll be working on that. I think Tom's probably stolen my thunder on the second bit, and it links to Jacqueline's comment, really. I think, Sarah, there are three approaches to the tooth decay and the tooth extraction. One is we're putting some effort and resource into reducing the waiting list. That's the very short-term piece. Medium-term links in with the local authority oral health strategies, and particularly supervised toothbrushing. As an ICB, we've put some non-recurrent support into some of the local authorities for this year to support that and to work with them. And then the latter one, which is the ultimate approach, because this is largely, if not highly preventable, is the fluoridation. So if we can get that fluoridation over the line, get the water fluoridated, that will have a big impact on public health, as you yourself, Chair, said earlier on.
Thank you very much. I'm just conscious that this report, the quality of the presentations and the data has improved a lot over the time that you've been doing it. But I know that some members, including myself, are still very opinionated about how data are used and presented. And we haven't ever taken that generic issue and debated it. And I'm wondering if it would need a longer, probably a half day, and we could do this at one of the board development sessions and then bring back to the public board meeting the outcome of those discussions. So I'd like to propose that if you were happy to participate in that.
I mean, I would really welcome that, Chair. I think there is a lot more we could do to improve the report further, and I suppose the only comment I'd make at this point is I feel like we've structured ourselves in our new ICB arrangements to bring the performance, BI and planning teams more closely together, and we're also investing this year in some additional support, particularly around developing the if you like, the public health observatory type function that will play back into the report. So I think some board input to how we shape that up. I think what we've got at the moment is a sort of collation of reports, but we could definitely reshape this into a sort of next generation report over the next 12 months.
I think it's the bit, the data information flow conversion is good. I think the information into insight is probably the bit that's needs further work, and everybody will have different views on what insights they would find valuable. So I think that would be a good debate to have. Sam?
Yeah, Chair, just to say I really welcome that. I think also in the spirit of seeking continuous improvement. We have also asked NHS England to review our integrated performance report, which they have done, and that's a piece of work they're looking at across all of the 42 integrated care boards, because obviously these are new organisations, and if you look at one integrated care board, you've seen one integrated care board, but we've sought a sort of a peer review on this particular piece of work. We've had some really constructive and valuable feedback on it. I'd also like to get to the point whereby we can also, we've got a system that enables us at one glance and touch to look at the indicators by local area as well. And I think particularly given some of the variation that exists across the North East and North Cumbria, so I'd certainly very much welcome that session and how we as a board can inform greater insight to help us do our work better.
Yeah, I mean, I've been complaining for years about, almost feel a victim of lack of access to information, but to my mind, the other paradigm shift would be when you want information that you no longer have to request it. You've got it. And we're still a long way away from that, in my opinion. And that is so basic, really, to anybody with any sort of curiosity who wants to explore a topic or wants to throw further light on something that they've read in one of these reports. To have to request it and then wait for the data to arrive, I just think it's in the dark ages, quite honestly. This discussion's generated further flags. So, Rajesh.
Sorry, Chair, it was just hidden away before. That's why probably behind Levi's computer. No, but totally support your suggestion to bring it back for a much more wider discussion. The question I had was on your report, Jacqueline. It's great to hear about what's happening in this region on out-of-area placements. But for that to be sustained, the real improvements have to be in community transformation of our services. And that will probably also help with many of the GP pressures which we are seeing. Are there any thoughts about how we are cited as a board on what is happening in that area, or is it too early?
Levi may want to comment. I was just going to say, sort of, if you like, generically, we are working with all of our transformation programmes. We've had a process of developing commissioning intentions around where further either transformations or investments are required to achieve the transformations that you're describing, whether they be in community services, mental health services, the neurodevelopmental pathway and so on. So all of this obviously is in the mix of the very difficult planning round that we're having and the financial challenges that we've got, but we are going through a process of trying to identify how we can incorporate plans to address our biggest challenges within the kind of wider context of the plan that you heard earlier. But Levi may want to say something more specific.
Yeah, thank you. If I may briefly. So our top 5 priorities for mental health, learning disabilities and autism for the year ahead include, one of them is inpatient and community transformation. So at the last mental health subcommittee, both of our main provider chief execs, James Duncan and Brent Kilmurray, were present, where we agreed that as one of the priorities for the year ahead. I think probably the twin track bit that will help with that, Rajesh, will be how we support the expansion of the integrated neighbourhood teams across all of our localities for the year ahead. So both of our main providers have committed to further transfer of resources, particularly primary mental health workers, into those integrated neighbourhood teams, wrapped around general practice, wrapped around smaller localities. And I think that's where we'll get the more responsive first approach to managing those kinds of issues.
Hannah.
Thank you very much. It's more of a reflection on some of the other comments that have been made, but and it taps into the inequalities bit as well. When we talk about prevention and we discuss other pressing issues that are affecting our local population and those nationally, things like lifestyle and sort of healthy habits and diet and things play a part, so particularly around managing, for example, obesity and also smoking, where we talk about the preventative elements there. Just an observation really, that when we talk about dentistry, we don't, and we talk about prevention, you know, some of these things like fluoridation and things are obviously very important, but also I haven't seen much and would really welcome more incorporation of some of those other lifestyle changes and the opportunities to educate around those, because as we've said, a lot of these problems are preventable, and primarily through diet they are preventable, and that's something that doesn't feature that heavily in some of our discussions at the moment around dentistry.
Neil, maybe the Healthier and Fairer Committee could help with refining the approach there, do you think?
Yeah, I mean, we do have programmes around, obviously, healthy weight, alcohol and tobacco, but you're right, actually focusing towards dental, because one of the biggest issues around gum disease are sugary foods, smoking, and then oral health, alcohol. So you're right, we could maybe tweak, can I say hand on heart, we've got a well-defined dental preventative strategy. I'm not sure we have, so we could look at that. Thanks.
Thank you. We'll take our break now. We've benefited from a bit of extra time, not by having longer to drink coffee, but by a really interesting discussion. So thank you, Jacqueline, for the report. We'll come back at 12:15 and then we'll be dealing with the finance report. Meeting of the Integrated Care Board for North East and North Cumbria. I'm moving now to item 9.2, which is the finance report, and that's going to be given by our Executive Director of Finance, David Chandler.
Thank you, Chair. Oh, I feel like I'm too close to the microphone now. So this is that time of year, Chair, where the board will look to me to provide assurance that we're going to achieve our 4 main financial duties. So I will pick them up in turn and hopefully provide that assurance. So the first one is the ICS financial position, and that covers, from a financial perspective, the ICB and our North East North Cumbria Foundation Trust provider trusts. And we have an agreed financial plan with NHS England, which is a deficit of £35 million, and we're on track to deliver that. There are a couple of risks that I mentioned in the report that total about £10 million, but I'm confident that we can and we will mitigate those financial risks between now and the end of the year. Within the report, I've mentioned that NHS England have allocated us £35 million of cash support funding. And this is funding that NHS England held centrally and are now providing to our system. It's important to note that this is not funding that we can actually spend. It's funding provided to reduce the size of our deficit, to bring us back down to break even. And the main reason for that is to reduce the cash borrowing costs in those provider trusts with a deficit. So we've allocated that resource accordingly. And what that means is that our forecast now to the end of the year will effectively be break even, which from a system point of view I think is a really good news story. But obviously, from a financial perspective, NHS England will still consider us to have had a deficit of £35 million and will be required to pay that back over 3 years, not from next year, but from the year after. If I move us on to the ICB position, we remain on track to deliver our planned financial surplus of £32 million. That's despite pressures that we felt all year through areas, especially on prescribing in CHC, which we've generally offset by slippage and non-recurrent savings elsewhere on the ICB side of things. And we have delivered all of our cost efficiencies that we plan to deliver. Within the paper, you'll see a proposal to the board today that aligned to what NHS England have done in terms of allocating cash to provider trusts to reduce borrowing costs. There's a proposal in the paper that we would reduce the ICB surplus from £32 million down to £4 million and use that £28 million to reduce borrowing costs or equivalent in our provider trusts that are currently running with deficits. Just be really clear, this is not money that can be spent. This is on anything from a revenue nature, so you can't use it to buy equipment or anything like that. It is simply moving cash around the system to reduce borrowing costs. And what we've asked for in the paper is delegated approval to the Chief Officer and myself that we will be able to, with delegated authority, allocate that on the most cost-effective basis across our system to provide FT trusts. The third financial duty relates to running costs. We are expected to not spend more than our running cost allocation. You can see in the report that we are forecasting a slight underspend on there compared to the amount we're allocated. That's in part down to the fact that redundancy costs in the ICB are now expected to be slightly less than forecast at the start of the year, Earlier we thought there'd be about £6 million. We think they're probably more coming now between 4.5 and £5 million. And we've had slippage on vacancies at the same time. So that's another good news story, because that's money that can be spent on programme services or clinical services rather than on running costs. The last duty relates to capital. You'll note in the report that I mentioned a risk related to IFRS 16, which is an accounting standard change. And I'm pleased to announce that NHS England are providing us capital funding to offset that pressure. We have in the last few days also been offered additional capital allocation resource, not cash backed, but it allows our foundation trust to spend a bit more money on capital equipment or backlog maintenance. In the last few days, we've had a few £1 million allocated to us, and that's been shared via the Capital Infrastructure Board across providers on an even basis, and they've been able to utilise that on things that they had ready to go. So that's another good news story. And I can confirm that we will not exceed our capital resource limit. In terms of 24-25, I'll just quickly give a quick update to the board in terms of our planning for next year. So we've already recognised at the board that from a financial perspective, this year was extremely challenging, and we expect next year to be even worse. We have submitted a draft financial plan to NHS England on the 22nd of March. That plan is unlikely to be accepted because it hasn't yet got us to a position of break-even or to a target level expected by NHS England. We have a further month to submit a system financial plan. That is due on the 2nd of May, and we'll bring that to the board for approval before it is sent in to NHS England. So that's all I wanted to say, Chair. Hope you take any questions or anything.
Comments and questions for David? Lisa.
Hi, yes. It was just when you say that next year is going to be a more challenging year than this year, obviously that's going to strike fear into the hearts of a lot of people. Do you have any idea on the impact of the more challenging year that we're going to have, what that could be on services, on communities, on staffing?
So it will be, one of the main reasons it'll be a challenging year, Lisa, is because of the headline rate of growth funding for the NHS and for the ICB and the ICS. So last year we received a 5% growth factor. Next year, 24-25, it's going to be around 2.5%. So effectively half the amount of growth funding. And that means it's very difficult to invest in new services. It's very difficult to pay for inflationary pressures and the like. And that's why we expect all providers and the ICB to have efficiency plans in place, as we have in previous years. Now, there will potentially be impacts of those efficiencies, but as we mentioned, the private board, every cost improvement plan should have a quality impact assessment. And it's also really important to ensure that where we have resources, and we have £7.5 billion to spend as an ICB, that we maximise the benefit from that. And quite often, the benefits from spending that resources can be multiplied, if we like. We're using that in the community setting, or we're using that in independent sector settings as well. So decision-making around that often sits at place or in the provider trusts, and they have mechanisms to ensure they maximise value for money, and they make the right decisions about how they use limited resources that they've got. So hopefully that provides you some assurance, and our nursing medical director are very close to that sort of thing as well.
Thank you. Hannah? No? Okay. John Rush.
David, just very supportive of the process to use the £28 million as you just described. But could you just explain what the process will actually be for the benefit of everybody on the board? And I know it's going to end up with a potentially a delegated decision for yourself and Sam, which again I fully support. But how is it going to be done?
Okay, so we will look at it from a value for money perspective. So the cost of borrowing for a foundation trust is generally 3.5% per annum, and you have to pay the cash back at some point as well. Okay, so that will be our first metric in terms of an assessment, in terms of who is borrowing cash and what's the cost to those organisations against those organisations that currently have deficits. We will also look to see if there are any other opportunities in those provider trusts in terms of anything that might exceed that 3.5%. So myself and Sam will have conversations with the chief execs of those three provider trusts, and then the ICB, myself and Sam, will make a decision managing any conflicts of interest to decide whether that is allocated to, and then we'll bring that to the board to give a clear update.
Eileen Kainer, a non-executive director.
David, thank you for your report. It's always clear, and I always feel I understand until I don't. Can we look outside our system just for a little while and just think about the perspective from NHS England? There are 42 ICSs in the country of hugely different scales and complexity, from populations of 350,000 to 3.1 million. We're one of the biggest and I think most complex. Do you get any sort of sense as we move toward an electoral change anyway, whether there's any discussions about what might be the right size, the perfect size, or whether any of the smaller ICSs may come together in some way to reduce running cost of having separate, very small ICSs?
I'll try and answer that question as best I can, although I suspect others in the room might also want to, but because it's not purely about the finances. But what I would say to you, from a financial perspective, I think Sir Liam has said this before as well, being a certain size allows you to have significant influence and impact on a strategic basis. So I would argue you'd want an ICB or an ICS to be of a size, not dissimilar to the size that we are, so you can make better strategic decisions. In terms of any thoughts for the future about any changes from any that might result from election, that's not something I'm party to. But I think that there's a general sense that we are certainly not too big, not too small, about the right size. Quite, you know, I try to avoid using porridge analogies, but that's what I would probably say.
At a historical perspective, because I looked at this with a colleague a few years ago, the so-called intermediate or regional tier since 1948 has varied between 0, 4, 12, 14, 28, 42. And the optimum, the figure that has stayed stable the most often is between 12 and 14, that sort of level. When it goes down to 4, it's not sustainable. And when it goes to 0, well, it lasted 10 years, but usually you would say it's not sustainable. You need an intermediate tier between the headquarters and the local service. Otherwise, things disintegrate into inequity in access and poor coordination, all of those things. Not everybody agrees, including those that are at the operational level, who generally argue that they don't need a layer above them. But the objective evidence shows that you do. And the best size, we're pretty close to the best size. And as resident historian Dan Jackson will tell us, there was a poor law region which was the exact footprint of this, and that was in the 1920s, 1918 actually, I think it was, something like that. Any other comments, questions? Thank you, David, then for that. And we'll now move on to a report on primary care access recovery, and Dave Gallagher, who is until the 1st of April, when his role changes, Executive Area Director.
Thank you, Chair. I have got a presentation which... there we go. Colleagues will remember we brought an update on primary care access recovery to board in November. NHS England asked that all ICBs bring a report in November, but also in March. Now, given some of the conversations we've had about performance and not having the full year picture at the end of the year, and we're not quite at the end of March yet, what I was going to propose to do is give a brief update on the progress that we've made, with a commitment to come back in May with a paper that describes the end-of-year report, if you like, for primary care access recovery. So just as a reminder, this all sits within the arrangement of 5 priorities for primary care, which, as we can read, are resilience and sustainability, access, integration, workforce, estates and digital, or infrastructure if you want to describe it as that, and then pharmacy, optometry and dentistry. We've got the fuller blueprint work that we're undertaking, and Levi mentioned earlier on about integrated neighbourhood teams, which is very much part of that. But within that sits the nationally driven primary care access recovery plan, which, to be fair, as we rehearsed last time, is largely general practice with a bit of pharmacy added in. So the 3 parts of that are around empowering patients, and again we've had conversations earlier today about the need to do and the importance of that, absolutely. Modern general practice access, building capacity and cutting bureaucracy, which is impeding some of the progress that general practices are making. And as a key part of that locally within North East North Cumbria, we've got an element of this which is supporting our deep end practices, which are those practices that work and operate within the most deprived areas in the North East and North Cumbria. So just to summarise where we're at last time when we brought the report to the board, we talked about the interdependencies, particularly interdependencies within general practice with acute and pharmacy, and we've rehearsed that earlier on as part of Sam's report in terms of some of the handover issues that we've got. We also talked about links with urgent care and with pharmacy, who have an increasing role to play within primary care and general practice particularly. And at the time, we recognised and the board highlighted some of those independencies, particularly around mental health, and we've got some work developing on that, particularly and really important to everybody, patient experience, but also the long-term financial impact to try and get to a system that is sustainable, which fits within David's previous report on the financial position. Just trying to work out if you need to click this so many times for it to work. So this is one slide that I want to dwell on a little bit, and again this is not complete for the end of the year and it's difficult to read, so apologies for that, but this is the dashboard that we're looking for primary care access recovery plan. So working across from the left as we look at it, the left hand box there at the top, there's an ambition within North East North Cumbria to get to 20 million appointments for general practice. And as you can see from the graph, or just about to see from the graph, there is a yellow horizontal line there that is that 20 million. The blue line is the graph showing recovery from COVID and shows that we're almost there but not quite. So we were at 19.5 million towards that 20 million. I would hope by the time we've got the end of the year figures that we'll hit that spot and say we've got towards the 20 million. There are two workforce metrics there. The middle one that's got the 2-point K is about general practitioner whole-time equivalents. And again, if you can make out the graph, we're almost there, making progress. So we're 93% of the way to the total ambition. And then the right-hand side is something called direct patient care, which is non-medics who work in general practice, sometimes referred to as ARS, Alternative Roles Reimbursement Scheme, which is the funding mechanism for it. And as you can see from the graph there, we're making progress towards the ambition for that. The bottom graphs, which I'll not go into all of them, but on the left-hand side, as you look at it, appointments on the same day, the bar charts there are actually for each of the ICBs within North Eastern Yorkshire. And for North East North Cumbria, we are at about 82%, 40% of that same day access. We're 41%. In North East Yorkshire, North East North Cumbria is 40%, so still a way to go within that, as there is with the appointments book within 14 days, and practices having at least one online consultation system, which is the second from the left box there. We're making progress on there, but the key bit is we're heading towards 73% of appointments being in person. And this is recognising that while a lot of the public want access to a person-to-person consultation, there are some areas where actually you don't need that, and you certainly don't need that with a GP. But that's where the information from the public experience, patient experience, comes in to try and manage and mitigate that. And this slide really is just an intent to show that actually, as part of all the metrics that we've got, one of the key bits we've got, working with Health Watch, working with practice surveys, the friends and family tests, and a range of issues to try and pull together the soft intelligence around this to make sure that we hear the messages from the public and patients and feed them into the plan. And again, we can update on that when we bring the final report in May. Just skip past that one. The timeline for this, as I mentioned earlier on, as the yellow box suggests, we're in March. We're bringing this interim update We're busy doing some work to look at the allocations for the various funding that comes from general practice. And colleagues remember the last time we discussed this, there's a plethora of various sizes of funding streams, but we're trying really hard to pull all of that together so we can make better strategic use of this as early as we can within the financial year. And ultimately we'll bring the end of year report to the board in May, which will outline all of this and demonstrate the way forward. We've got some conversations as part of handover in April where we look to try and streamline the work that we're doing on primary care and general practice, and that will feed into that report. So Charles, I'm going to pause there, but happy to take any comments or questions.
Thank you very much. Well, it's an update and a brief time for this before we move on, and obviously we'll be hearing about it at later meetings. Are there any points for today that anyone wants to raise? John?
Just a quick one, David. You talked there before about patient participation groups and that you were going to report back next time where we were with those. Just at the moment then, do you know how many practices actually having them, or whether they're consolidating them around primary care networks or anything like that? Because it was potentially a key part of how to support the community and that linkage. So I'm just wondering what the take in that is at the moment.
So John, I haven't got the data to hand, but happy to share that. I think there are a good number of practices that do use their PPGs, patient participation groups, really well. Inevitably, there are some that don't. And I think your last point is really important, where practices are increasingly working together, either as large conurbations of practice or as primary care networks. They're joining some of that up. The new arrangements that we've got as part of the ICB 2.0 work puts in more senior resource into the local delivery teams, the 6 of them, and they'll be working really hard supporting their practices locally. But we'll bring the data back for you.
Yes.
Thank you. Just to pick up on that, it might be something that we can take forward in patient voice as well, and then feed into quality committee. We do have updates from primary care, but I'm not sure that we've looked at this particular part of it in great sort of granular detail. That's certainly something we could maybe look to do, and then bring back to quality committee and back here later.
Okay, thank you. Claire Riley.
Yeah, and it's just to support David with regards to the work of the PPGs. It is patchy. It depends on the different organisation and the arrangements that are put in place locally. What I would also add, John, is what we're keen to do is try and work with the local PCNs and the local organisations to make sure that they are representative of the population that they serve. So similar to Council of Governors for Foundation Trusts too, what's really important is it's not just somebody sitting in a group. It's making sure that they represent the community that they operate within, and there's a lot of work to do around that, and I know that it's already part of the People and Community strategy.
Thank you. Moving on then to item 9.4, and this is to do with VCSE, Voluntary Community and Social Enterprise work. It's an update and confirmation of the Memorandum of Understanding that we have in this area, and Claire Riley is going to present, and Lisa Taylor, one of our partner members who is from the VCSE world, is going to also participate in this item.
Thank you, Chairman, and thank you for the opportunity to share with you our work with regards to the voluntary community and social enterprise sector. It's fair to say that this work is evolving, and I'm pleased that Lisa is here to be able to share with you the work of the Memorandum of Understanding. But it's important to note that our work regarding the coordination with the sector actually predates the Integrated Care Board and the creation of the Integrated Care Board. It's actually into its 4th year, working with certainly VON and also looking at coordinating across our integrated care system, recognising that actually things evolve, things change, and I wanted to make sure that this work shares with you definitely an evolving picture, with a view that later on in the year we will bring back a more detailed report. But our ambition and our commitment to work with the voluntary and community sector is not in doubt, and I think that commitment started pre the ICB and has continued as we have worked as an integrated care board. If you look at the statistics, around £50 million is invested in voluntary and community sector organisations across our region at any given time. Yes, that includes large contracts with some of the large organisations, but also it includes investing with small grants in some of the smaller organisations. And as you can imagine, that it's really important to try and understand the sector. The sector itself is not one homogenous group. It is not easy to understand. There is well over 11,000 different organisations operating. They are large, they are small, they are medium. They do lots of different things, most of which could actually be connected to health and well-being if you really look at the work that they are doing. And obviously, as you can appreciate, we can't fund every single one. And what our ambition is really to look at the sector, develop plans which will come further in the year, and align all of our work and our funding plans linked to the delivery of the Better Health and Wellbeing for All strategy. What is clear, however, there is a national expectation that we do this work, but I'm pleased to say, and hopefully Lisa will touch on it as I pass over to Lisa, about some of our work that has been seen as a national exemplar, working with the sector, working with VON. And our original plans 4 years ago were developed in partnership with NHS England and actually part funded by NHS England at the time. But we were delighted to host Amanda Pritchard in the region on Friday. And it was a great opportunity to share with her some of the work we are doing with the voluntary community sector and actually highlight especially areas around mental health. And we had a visit to Everyday, and I'm delighted that it was actually referenced in her blog yesterday, which is really good to see. But this is complex. If you look at the local infrastructure organisations, we are working with VON, but actually each of the local areas have local infrastructure organisations. Now, I appreciate that that slide might be difficult to see, but what you can see is lots of organisations. And therefore, when there are lots of organisations, it's really important that we have a clear plan, but it's recognising that it is complex and these things do not happen overnight. And notwithstanding that, those are the local infrastructure organisations. That doesn't necessarily take into account all of, obviously, the organisations that are operating locally in delivering some of the health and wellbeing activity on the ground. So developing our partnership programme, we do have some challenges to overcome, and this is something that we will work with the voluntary and community sector as we evolve throughout the year and develop the next model, it's fair to say, of how we will work going forward. And we are keen to engage with the sector. I've already started to talk to the local infrastructure organisations. We have an ongoing dialogue with VON, and we are part of the partnership programme, and that is something that we are funding for the year ahead. And what we will develop is a very clear infrastructure on how we will work both with the local infrastructure organisations and also how we will support local organisations delivering what they need to deliver, recognising that it's really important that, again, we align it to all of the work that we do for better health and wellbeing for all, but we also create an evidence base on the work that is delivered on the ground so we can demonstrate the impact that it creates. But I mentioned earlier that it's complex. Now, this is the partnership programme integration structure. You can see that this is not a simple structure. It's not an easy diagram to read, and I appreciate, sorry, that you might not be able to read it on that screen. But that pales into insignificance. And you're not meant to see this, but it sort of pales into insignificance when you actually look at the partnership structure across the region. So it's important to say that we're going to take stock. We're going to use this year as an opportunity to really look at our infrastructure and how we work together, with a view that we'll learn from what we've done over the last few years, and we'll have a programme of work going forward. So next steps is obviously to agree the memorandum of understanding, and that's something that we have done with VON, and that is really good progress, and Lisa will share with you the detail of that. We will carry on our stock take to really look at the market of the voluntary and community sector in our region, and to really look at what is the work that we need to fund and support going forward that will create that evidence base aligned to the Better Health and Wellbeing for All programme. And we will utilise the learning from the ongoing pilots that we have done over the past few years. Lisa, over to you.
Thank you, Claire, and apologies for that busy slide, which we lovingly refer to as our slide of doom. We're aware it's quite hectic. But just to pick up on what Claire said there, the VCSE Partnership Programme is our voluntary sector alliance which spans the footprint of the ICS. VON, Voluntary Organisations Network North East, is our regional infrastructure organisation for the voluntary sector, one of only 3 in the country, so we're really lucky to actually have one. And because our ICS spans over the border into North Cumbria, we partnered with Cumbria CVS to ensure that the partnership programme is delivered in alignment with the footprint, the geographic footprint of what we do. But so we involved the entire voluntary sector, or those who wanted to be involved anyway, in developing the Memorandum of Understanding. It was initially created within our programme steering group, of which we have voluntary sector, ICB and clinical membership, to ensure that everything that we do is aligned with priorities of everybody within our system. And the process for that involved wide consultation with the whole sector, as I say, and it's been an ongoing, we created it. It was going to come to the ICB for this meeting for signing off in November 2022, but due to ICB 2.0, and well, you're all aware of everything that's happened, it's been pushed back. So we actually did a review of the Memorandum of Understanding to ensure that it was still relevant to everybody, and there have been some changes put into it as a result of that. But the MOU, as it stands now, is a document that's going to underpin the relationship between the voluntary sector and all of our colleagues within the ICS at every level where we intersect. The key points outlined on the slide there recognises that the voluntary sector is a key and equal partner in achieving the ICB's shared ambitions, and I'm sure nobody would disagree with that. It also commits the ICB to action and to the involvement of the VCSE at system and place level, and that's to make sure that there's the understanding that the voluntary sector is not just a lone voice on a board. It's not just a person at a place. It's embedded in everything that we do, and supports every aspect of the work that we do within our communities and up to strategic level as well. The MOU also promotes connectivity and collaboration and communication within the voluntary sector and the ICB. So that's talking about making sure that we are having conversations and discussing things. There's a good phrase, nothing about us without us, and I think this applies really well here. Anything to do with the voluntary sector should involve us in the conversation. Anything to do with communities should involve communities, and that's a value that's underpinning everything that we're doing. And it also commits the ICB to support the partnership programme as the Alliance for the North East and North Cumbria. I don't have a... Oh, thank you. So the... As I say, the MOU in its creation is predominantly values-based, and we wanted it to draw on the commonalities between our two sectors rather than being something that would be holding one sector to account on behalf of the other. As I say, it's been created with a huge range of feedback from organisations. We've had feedback from all sizes of organisations, from all localities of our ICS, so the content itself is representative of a good representation of what the sector would like to see within it. And I think one of the key things about the MOU is that as a system we need to acknowledge that partnership working can be really challenging, and the relationship between the voluntary sector and health isn't always easy, and I think there's a huge cultural shift required in order to move our integrated care system into something that is a system and it's not just a component of its different parts. And hopefully the MOU will help to move this work forward, but that work needs to happen on both sides. It's not the responsibility of one sector or the other, it's everybody working together. We've got annual reviews built into the MOU to make sure that it's not just something that's going to sit on a shelf, it's an active document that's going to be measured against progress. And one of the things that Claire alluded to earlier was that we are, last year we became one of the test and learn sites for an NHS England quality development tool around addressing the barriers to inclusion of the VCSE sector within integrated care systems. It's a really snappy title. But it's a really good document that's been co-produced with a number of, I think 6 different integrated care systems with teams of voluntary sector and ICB members. And it looks at a huge amount of different areas in which traditionally there can be barriers that would stop the two systems from integrating together. So that's something that we're going to be looking at on an annual basis to make sure that, as well as the values and everything else in the MOU, that actually the practical work that can happen to make these difficulties be overcome is continually being assessed and progressed. And that's quite a positive, I feel, as a system, and it shows that there is the will of the ICB to do these things that support and promote the relationship with the voluntary sector. So, you know, the ICS footprint is a new one to us as a sector as well, and you know, there's no hierarchy within the voluntary sector. We are entirely independent organisations. There isn't a boss of the voluntary sector. No one organisation is more important than another. Everyone is equal, and everyone does a job that supports the health system to carry on. So we've also actually, the model of support that Claire showed, the partnership programme, is actually been touted by NHS England as a model of best practice for complex and larger ICSs. So I think that's another feather in our cap as well. And we've actually been involved in supporting other integrated care systems to develop their voluntary sector alliances as well. So I really feel like what we're doing here could be one of the jewels in the crown of our integrated care system. But I'm happy to take any questions or comments.
Okay, thank you very much to both of you. So we'll open it up to questions and comments. Kath? Do we need to go a bit closer to the microphone?
And switching on, actually, as well, so that would be helpful. Not that anybody says that to me normally. I don't know whether it's a question or a comment, but I think there's such a lot of work that goes on around what happens within the voluntary and community sector, and every local authority works collaboratively with the voluntary and community sector. We all do our own process mapping depending on what kind of area we're talking about, and I certainly know that we're looking at a children's mapping exercise across our city, but equally other local authorities have also done that, and it's just about how can we join all of that up in terms of an infrastructure rather than us constantly going to Vaughan or to our own individual organisations to kind of pull all of that together.
Yeah, Kath, we've actually started the conversation with local authority partners regarding this, and I think that's really, really important area. What we're also hearing is that we need to look at the meeting infrastructure, because very often, certainly the smaller organisations don't have the time to invest in coming to some of the meetings too. So we need to look at and refine that, but we also need to align it to some of our work with the local infrastructure organisations and also with local authorities.
Lisa, do you want to add something to that?
Yeah, it was just around the sort of mapping exercises. Within the voluntary sector, mapping is really quite difficult often because of the instability of funding for key services and organisations as well. So mapping is a really good idea, but in practice it takes a long time, a lot of investment, and needs to be done constantly. It can't just be a one-off.
John Rush, you've had quite a long-standing involvement in this area.
And I will say, for a declaration of interest, I am a trustee of an infrastructure organisation in Cumbria, so that's that. Yeah, I suppose we're at the stage, I mean, I was involved prior to the setting up of the ICB of the work that Lisa talked about and how it was all set up and to try and get that structure. So very much seeing all those different plans was part of what that role did. I think we're absolutely right to have a review of where we are. I think it's a very difficult piece of work for many reasons. I mean, the main reason being the size and the disparity of all the different organisations. You're never going to get a perfect result on it. I think what I'd like to see, I suppose, at the end of all of it is, okay, what's our model of engagement with the different structures and different organisations? We've talked before about engaging through Vaughan and through that wider network and the CVS over in Cumbria as well, and the work that Lisa does. But I'd be wanting to know, okay, as regards the £50 million, some of the £50 million will be used for statutory responsibilities which we have as an NHS, and they were discharged through some organisations. Some of it will be through smaller grant funding, some of it will be through sort of place-based work as well. So I suppose it's a quite, okay, what will the engagement be and how will we do it? I think it's going to be very difficult for one or two people to lead all that. If we do that, then how do we support financially the organisations to be able to create that engagement? And then really as well, okay, is that don't give one up for the sake of the other. So I would say don't give up giving the grants to smaller organisations in specific areas for the benefit of one big infrastructure organisation which has the capacity in the HR department to run the whole thing for wherever. It needs to be a continuum. And I think that's what I suppose I'd like to see in the end. But I think the time is right now to actually do that review and see what comes out of it.
Yeah, John, that is exactly the plan, and you are absolutely right to ward against the smaller grants being impacted as a result of some of the larger organisations, and that's certainly not where we want to get to. Where we also want to get to is looking at the short-termism around the grant awarding. That doesn't help the voluntary and community sector at all. We need to look at longer-term arrangements around grant awarding powers too. And actually, what that needs to happen at a place level, and that is best where that happens. But I do think it is a tough piece of work. We're fair on with it, if I'm honest, and trying to understand the market has been quite difficult. But there will be challenges. I said earlier that we can't fund everyone. And we will have to be quite brave with that. But actually, there are also opportunities. And I think the opportunities bring with it potentially bidding for joint funding and a range of different other opportunities too. So I'm quite optimistic.
Levi Buckley.
Thank you. I've put my indicator down as John largely picked up my question, but I will take the opportunity. I think, Lisa, some great work, and the plurality of providers means it is a challenge, as you say, to act as a voice on behalf of all the communities. So I suppose as we evolve the MOU and this process, very happy to work to think how do we make sure that the place committees continue to have some local VCSE voices, and how we maybe think about the scale we do that to make sure that they're all aware of the opportunities, our work programmes and those interfaces. So yeah, I'm looking forward to this for the year ahead.
Okay, we need to break for lunch now, but I'd like to thank Claire and Lisa for the work, the presentation today, and we'll keep in touch with what's happening at board level. So thank you very much indeed. Yes, John.
Just before you break, just on a point of sort of governance, I just want to make it really clear on the bit that we did for the £28 million. I don't think we actually asked for board approval for the method to be used that we talked about for Sam and for David to be. I know I supported it, but I just think it'd be important just to note in the minutes that the board approved it, if that indeed is the case about the process.
Yeah, okay. Is everybody happy to approve that? Yeah. Remember the discussion. Thank you very much. Okay, we'll break for lunch, and then if we could be back promptly, because I know a lot of people have got to be definitely away by the 3 o'clock meeting time. So if we could be back promptly at 25 past the bill. Check that we're all set to go back online. We are. So it's resuming the Integrated Care Board meeting, Integrated Care Board for North East and North Cumbria. And we're now on to item 9.5, the Clinical Strategic Plan, and Neil O'Brien, our Executive Medical Director, is going to present that. And I do remember that Ken Bremner's been quite heavily involved in clinical strategies, so may want to comment at some point. But Neil, go ahead.
Thank you, Chair. So, yes, thanks everyone. I'm really quite excited to bring the first cut of our clinical conditions strategic plan. Before I get into this, I just want to put a little bit of context behind this and how we've arrived at this approach in our strategic planning. We have our Better Health and Wellbeing Strategy for All, the ICP strategy, and what this piece of work is attempting to do is to look at what can the health service do in all of the activities that we do to patients and the public that will have the greatest impact on reducing health inequity, improving and providing healthier, longer lives. What it's not is a complete strategy of how the health service should work or be configured. We have used very much a data-driven approach to prioritise, and it is about prioritisation. It doesn't mean that conditions that are not within this are not important. There will be obviously various different priorities, quality issues for other conditions that will come up during the next 5 years, which is the duration of the strategic plan, that we will need to address. But this is a very structured piece of work that we have tried to do to look at the clinical conditions that have the greatest impact on our population in the North East and North Cumbria. So, this first slide, I know is quite busy, but I'm going to just go through some of this, and it highlights why we've come to the clinical conditions that we have. We know that there is a variation in healthy life expectancy in the North East, and that is very much related to deprivation, and that there is about a 10-year gap between the most and least deprived populations within the country and within the North East and North Cumbria. We know that there are a number of long-term conditions within the North East that, and the most prevalent are anxiety and depression. 21% of our adult population have anxiety, and this data is derived from coding of general practice data, so it is quite accurate. 17% of our population have high blood pressure, 15% have depression, 7% diabetes, and 7% have asthma. There are about 28% of people living in the North East and North Cumbria with 2 or more long-term conditions. 16% are smoking, and 38% are obese, and 19% have increased or high levels of alcohol consumption. Within our children and young people, 4% have diagnosed of having autism. I was absolutely astounded by that figure because it's the same amount, the same prevalence as those children that have asthma. This condition, and that is reflected in our priority setting as we move through the presentation. 2% of our children actually experience anxiety, and 0.5% of them have learning disabilities. There are still too many deaths by suicide, and tragically from 2018-19 to 2022-23, there were 31 deaths by suicide of individuals aged between 7 to 18 in the North East and North Cumbria. And these are things that I think we really need to start to get to grips with. Within our adult population, there's about 94 people per 100,000 that have lung cancer. and there is a massive variation in deprivation. And unfortunately, we diagnose a lot of our lung cancers, which I'll show later on, at a later stage, although that is improving. Nearly 10% of our adult population have respiratory disease. There are 36,500 attendances to A&E for people with back pain. And about 60% of adults actually experience back pain, which then has a resulting impact on prescribing of painkillers, not being able to work, and then if they're unable to work, that then leads to other problems such as deprivation and all the problems that have been associated with that. 20% of our population have more than 3 risk factors for circulatory disease, for heart disease, in the North East and North Cumbria. So I've spent some time on that to try and paint the picture of almost the burden of disease within the North East and North Cumbria, and this is the data which we have tried to use in the most accurate source that we have to base our recommendations and the prioritisation. So our vision is that we're going to use population health information to get the best outcomes from health services in the North East and North Cumbria. We're going to focus the NHS workforce and all of the resources into a smaller number of health conditions to try and get the greatest impact. And we'll do this using a number of principles that we're going to try and shift from reactive hospital-based care to more proactive approaches and prevention, that is primary prevention and secondary prevention and early intervention. We'll look to try and stamp out any unwarranted variation in clinical practice and pathways, try and focus on personalised prevention and self-care, develop new models of care in our priority setting, address healthcare inequalities in access, experience and outcomes. We'll try and improve the outcomes for people with multimorbidity, look to try and do the most value-based healthcare possible to improve efficiency, and try and adopt new technology and innovation rapidly in these conditions. We have our approach in developing this strategic plan was very much not looking at this in isolation, but how does this fit with all of the other work and strategic plans across the ICB. It's very much underpinned, and there's a strong theme of prevention within this plan, because that is the area that we will need to focus on in order to have the best outcome for our population. This clinical conditions plan should provide a framework for us to work on through all of the different work streams over the next 5 to 6 years. We've used a population health management approach, and all of our recommendations have data behind them. And when we bring the final document to board, that you'll be able to have access to all of that data through an appendix. It's all evidence-based, and the interventions that we are suggesting are also evidence-based. We've based this very much on clinical multi-professional engagement across the system, using all of our professional networks to come up with the recommendations today. There's absolute alignment with both regional and national policies, such as the Core 20+5 and the Major Conditions Strategy, which was published last year. And so it's very much trying to take all of the work that's been done nationally, look at the evidence, look at our population in the North East and North Cumbria, and distill that down to a smaller number of priority areas for both adults and children. We used a prioritisation framework, and we've weighted this differently for adults and children, but the weighting was very much based on the amount a condition contributes to premature mortality for adults, the contribution to the life expectancy gap, and those two there really are what drives the inequity in life expectancy. We've looked at the global burden of disease study and looked at morbidity and risk factors and weighted those appropriately. And then we've looked at prevalence and resource utilisation. It's slightly different for children after discussion with our specialists in this area, where there's more weighting on lifetime impact, effectiveness of any interventions that we have, and the scale of inequity. And that's reflected in some of the conditions that have come forward for children. One of the early bits of feedback is, why is obesity included in children and not in adults? And the reason for that is because the lifetime impact, if a child is obese when they leave primary school, is so much greater, which is why we think it's legitimate to include that in the children's priorities. So here they are. These are the headlines of the clinical priority areas. I don't have time today to go through each one of these in detail, but I will give two examples to show some of the data that we have behind this and give you a flavour of what the recommendations will look like, and a summary table which will show some of the specific recommendations that we're making for each of these. But they are lung cancer, cardiovascular health, respiratory health, low back pain, anxiety and depression for adults. And then in children and young people, it's diabetes care, asthma, epilepsy, obesity, oral health, anxiety and mental health, and autism and learning disabilities. Now, we've tested these with all of our professional networks. We've engaged a lot of clinical groups around the North East and North Cumbria, and we have consensus that these are the priority areas to be focused on. This is an example of some of the data that we have, and this is an example of the lung cancer data. And we have similar amounts of data for all of the priority areas that I've just shown you. So lung cancer is one of the leading causes of premature mortality and the gap in life expectancy in the North East and North Cumbria. And we have in every single of one of our places, the incidence of lung cancer is higher than the England average. Unfortunately, the country doesn't perform well in actually diagnosing lung cancer early. Still, half of them are diagnosed at stage 4, which very much limits treatment options. There is the Targeted Lung Health Check programme, which is already underway, and that is starting to show early promise in changing the shift of the stage at diagnosis, which we believe will greatly improve the mortality for individuals who have lung cancer. This slide is an example of what the lung cancer recommendations, and therefore for each of those areas we will have a list of these recommendations, will look like. And they've been developed in collaboration with the Northern Cancer Alliance and the Healthier and Fairer programme. So the recommendations, as hopefully you'll be able to see, are very specific, and we should be able to report to board throughout the next 5 years how we are performing against these. When we come with the final document, the other bit of information that I will have for you is that if we do perform better on all of these, what will be the expected improvement for our population, which will hopefully again solidify some of the evidence as to why these are the right things to focus on. So the lung cancer recommendations are continue to support the Healthier and Fairer programme in the tobacco control strategy and get to 5% by 2030. We'll scale up the targeted lung health checks and be more ambitious and try to get 100% coverage before the 2030 target. Look at reducing barriers in access to service of diagnostics and make sure that we have equity of access, and then effective treatments once an individual is diagnosed, and then embed a holistic approach of improving fitness and management of comorbidities of individuals with lung cancer. So these are all very specific recommendations which relate to clinical care, and we have those for all of the conditions that I've mentioned. The next example is a children's one, and it's the obesity in children and young people. This slide just again highlights the scale of the challenge, and that the prevalence of obesity at the end of primary school is really getting quite high, to the about 23-24%, and there is variation in our more deprived populations and in some of our ethnic minority groups as well, which we will need to try and address. Therefore, the recommendations, again, hopefully you'll see that they are quite specific and they have been developed in collaboration with the Children and Young People's Network, is that we will support the development of a regional whole system approach for healthy weight and treating obesity. So that will be around the more public health approach, the obesogenic environment, healthy weight and diet. And so the NHS will absolutely commit and contribute to that. We'll take a family approach, making every contact count to offer opportunistic intervention. Deliver improved recording in weight and BMI in primary care. Ensure that children and young people have access to weight management services, including dietetics, healthy weight, psychology services and weight management for all those who need it. And ensure that we have sustainable long-term tertiary referral centres where that is required in children. So again, there's a mix of prevention, the NHS's contributions to working with partners, but also some very specific things that the health service will need to provide equitable access for children who are living with obesity. This next slide is a summary slide, which I'll quickly rattle through, but again, I just want you to, hopefully, it will show you the very specific nature of the recommendations that we are making. I've already mentioned the recommendations on lung cancer. In cardiovascular health, it will be very much focused around proactive case finding in primary care and improvements in the treatment of atrial fibrillation, high blood pressure, and cholesterol, and optimizing these risk factors. In respiratory health, it's really about accurate diagnosis and then ensuring that our population have the best treatment pathways delivered by the health service and that we look at symptom-led prehabilitation and rehabilitation for those with respiratory problems. In lower back pain, we think and we can see from the evidence that there are far too many pathways around the North East and North Cumbria. The experience of patients who have low back pain is variable in access to diagnostics. Some people are being over-investigated, some people are not. The access to physiotherapy and other therapies is variable across the patch. So quite plainly, we want to look at a new model for back pain with a single point of access for MSK. And there is an evidence-based national back pain pathway, which has been well described, that we will look to implement across the North East and North Cumbria. In an anxiety and depression, it is very much supporting the direction that has been already laid out by the mental health and work stream, which is really looking out to roll out integrated community models of care to get improved early access to therapies for those with anxiety and depression. This slide is for the children's. Again, very specific. I'll not go through every single one of these, but there is a theme around access to multidisciplinary teams. It's equitable access to specialists who can help to look after children who have these conditions that can have a lifelong impact on their health. It's very much focused around the prevention, early detection and access to specialists and new technologies, whilst ensuring that we deliver nationally agreed models of care, reduce health inequity and meet the Core 20+5 recommendations. My last slide is just to show the Core 20+5. We're not ignoring this. This clinical prioritization does is say we will deliver the Core 20+5 because these have good evidence in reducing health inequity across the country, but we will go further than that and deliver the improvements in those areas that we've highlighted through an evidence-based approach, which is why which we believe will have the greatest impact for our population. So once we've, what I'm seeking today is support from the board on our approach. At a future board, we will bring back the full document, which will include those slides that I have shown you for the 2 conditions, but for all of them, including the expected outcomes that we could expect to have if we do indeed deliver improvements in those areas, and also a plan around how we would start to deliver that. Thank you.
Thank you very much, Neil. So open it up to questions and comments, please. Tom Hall, partner member.
Thanks, Neil, and just to thank you first and foremost for the way in which you and the team have approached this. I think it has been a really engaging exercise, and I've seen versions of that presentation, not least the in-depth look at the data, several times over through the DPH network and our Healthcare Public Health Network, so thank you. We still operate in a system where we go this way for lungs, that way for backs, this way for minds, and again, I know from the data slides that 28% of our North Cumbria population have 2 or more long-term conditions. I'm just wondering where multiple morbidity starts to fit in all of this.
Yes, and that has come up in the engagement, and I think what we've done with this is actually identified the conditions that have the greatest impact. How we manage multi-morbidity continuity, I think, is very much embedded in the quality improvement that's required in our general practice models of care, but also how we integrate models of care within and around our communities. Yes, I understand the issue around multimorbidity. There's that, and also polypharmacy and overprescribing, which all need to be woven into how we deliver some of this work. I think we do need to do a lot more work on how we do coordinate care, but this is very much about these are the conditions that we need to focus on. I think there is some separate work to be done on how we actually coordinate better across primary, secondary care.
Hannah Bowes, Non-Executive Director.
Thank you. Yeah, just echo, really welcome this, and the fact that it's been data-led, data-driven, I think is obviously where we want it to be, and that's great. The one thing I was going to just ask or maybe comment on is around these key priority areas. Obviously, you've noted that there is a variation or differentiation in relation to some sort of markers of social inequalities and different demographic groups. So what I was going to ask is basically how you will account for that or factor that in, not only in terms of your sort of targets, what you would expect to see change, but also how some of these recommendations might actually operationally be a bit different, or even strategically might be a bit different with those different groups taking into consideration those important differences.
Yeah, so you're right. How we deliver these interventions does absolutely need to be tailored towards the populations that we are trying to target. And we've got numerous examples of how we've done that with various different strategic plans before. So in some of the cancer work that we've been doing, and how we target more deprived populations around some cardiovascular risk management. So I think how we do it will have to take into account how we access those that maybe aren't as digitally enabled as others, and then around actual physical access and getting to because often some of these interventions are hospital based. How do we change that? How do we get that some of these treatments into people's communities? And our spirometry example is a good one for that. So I think that question and how we do that, but how we provide equitable access and reduce the impact of inequality, we would want to see as an overriding principle in the delivery plans for all of these. Yes, it's a very valid question, and we should be able to answer it in all of the plans.
Thank you. Thanks, Neil. I found that a very, very in-depth presentation. I really enjoyed it. I think it really gives us a very clear snapshot of an overview of what is happening on a population health level across the North East North Cumbria area. My question was around diagnostics access, because obviously primary care is the first point of contact for many long-term condition diagnosis, but obviously diagnostics plays an essential part of that. Just with the variability in workforce, the nursing staff were 40.4% retiring in the next 5 years, looking at our demographic charts in primary care. My question was, how are we ensuring that we are able to offer that diagnostic at the first point of contact? And also, do we have equitable access to diagnostics like x-rays and ultrasounds within primary care?
So we know that there's not variable access to diagnostics, and just one point on diagnostics, I think that there are some basic investigations that all primary care clinicians should have easy access to. There are some areas within the North East and North Cumbria that have access to many more diagnostic tests than others. And actually, the work that we've done on back pain shows that a large proportion of the MRI scans that are done for back pain were never indicated, really. So there's an opportunity in looking at diagnostics and both improving access but removing waste, and therefore that time that has been used in scanning lots of people's backs who maybe didn't need a scan to begin with could then be used for imaging for other clinical priorities. So there is a big piece of work to do around access to diagnostics, because a lot of the interventions are very specific on improved diagnosis rates. So yes, there is work to be done, and there is variation which through this prioritisation process we will seek to address.
Okay, we've got 7 people wanting to talk, and that will take us way over time. So what I'd like to do is to take the 7, Neil, or in 2 batches, and then get you to respond not one by one, because that will be better use of time, I think, at this stage. Lisa Taylor.
Thanks. It was a lot of the recommendations that you've talked about around based on prevention within communities, and voluntary sector organisations provide a lot of this, as well as a holistic and person-centred approach, and that's very effective, especially when dealing with communities that are traditionally quite difficult for health to reach into. One of the issues that the voluntary sector has is around collection and collation of evidence, so we can provide an evidence-based approach for our service delivery and delivery of outcomes. Is that something that you would be considering? Because I know Healthier and Fairer traditionally is a really good place for partnership working with the voluntary sector, but it's taken it to the next level on outcomes monitoring.
Okay, thank you. Ken Bremner.
2 comments. One, to support the work that Neil's done focusing on clinical conditions. I think that's an excellent piece of work and gives us a really good framework moving forward. The second was more reassurance. As you know, we're doing some work through the Provider Collaborative on, as you mentioned, Liam, the clinical strategy. We are focusing very much, particularly in the initial phases, on acute services, and in particular looking at where we've got inconsistency and variation, where we have issues around critical mass going forward. And by critical mass, I mean a population size that is sufficient to enable the right sort of investments in things like digital, thinking of things like robotics in particular, but other issues as well, and where we've got undoubted issues of sustainability of services facing us in coming years at the same time. So we will focus our work on those 3 areas in particular, but we will be working with Neil and the team and the ICB and vice versa to make sure we have a joined-up approach so nothing falls in between those 2 stools. What we're not doing at the moment is venturing into areas like primary care, community care, social care. That still needs to be picked up, and that's why the integration is so important with the work Neil's doing to get a position for the whole system. But the Foundation Trust will be focusing on those areas, particularly in the first instance.
Thank you. Eileen Kaner.
It's back on the theme of multiple long-term conditions and integration. You mentioned primary secondary care, but mental health care and acute care is a key one. There is a strong evidence base around liaison psychiatry and increasing models where people from more generalist provision are providing liaison psychiatric sort of support. Everybody with a long-term condition has an emotional or psychological response to that, and so support around processing that condition and then trying to kind of manage that Equally, looking at children and young people with serious conditions, again, mental health management is absolutely crucial there, particularly with the rates of self-harm that we have.
Thank you. John Rush.
Yeah, just really quickly, just looking at the work that's been done and trying to see how it fits into the current ICP plans and the ICS plans, to make sure it doesn't contradict. I don't think it does, but I just want to make on that point. And then secondly, obviously, if you bring in delivery plans at some stage, just the costings of what these things would be, and because we may not be able to afford all of it, but we should be able, if we're talking about these as priorities, then that's what we should be doing, and that involves a different approach to what we're going to give up to be able to do this.
Neil, do you want to deal with those? And then there's 3 more to come.
So I can, yeah. So on the prevention side, I think the main driver for our work on prevention is healthier and fairer, and the voluntary sector are well stitched into that. So we'll certainly continue with that engagement. On the acute clinical strategy, and we are linked and working together with the provider collaborative, and really this strategic plan underpinning that, there should be a plan for acute services. We've got our plans for mental health services, a plan for general practice. That really should be able to see the link. A good example of that is planning the workforce and the service requirements as a result of targeted lung health checks. That will cross a number of our strategic plans that we need to ensure that we pick up. On delivery, really we're looking at this would be starting to get delivered in the year 25-26. We need to ensure we've got absolute buy-in and backing good delivery plans in place, which would then feed into our commissioning intentions for the following year. It doesn't mean we'd have to wait for a lot of the improvement work until then, but any of them that are going to require any significant resource implications, I think would have to be looking for next year.
Okay, thank you. Sam?
Yeah, it's just more of a comment, really. I think when the excellent piece of work, one of the areas for me, though, is also about the models that enable this to happen, and just ensuring that when we're looking at the clinical conditions, we're also thinking about a mindset of a more biopsychosocial approach, because just to use the example of anxiety and depression and the link to low back pain and vice versa, we need to really also make sure that any models of care we are looking at the whole person and really holistically. So it was just really to make that comment, but thank you, Neil, for that work.
Thank you. David Chandler.
Yeah, thanks, Chair. Thanks, Neil. Just wanted to commend the work that you've done so far. It's fabulous in terms of being able to identify what the priorities are in terms of, in a world of limited resources. That's fabulous. My question was going to be, we get a lot of initiatives, don't we, in the NHS that come down, etc. So I'm just wondering, will you be given some thought? Have you given some thought in terms of how do we ensure, staff, patients, the wider public know what the priorities are, but probably just as importantly, know why they're the priorities? Because you want, I presume, everybody to be behind this, if that makes sense, in terms of making the difference.
And then finally, Rajesh Nagarkar.
Yeah. Just couldn't speak there. Thanks, Neil. Again, just as others have said, excellent piece of work. Just two sort of comments. The first thing is linked to the how, what, and where of this strategy. And linked slightly to even Sam's point, I think there would be some value in also giving a steer that the where of what happens, whether it's led through the local delivery teams and all, we'll look at all the developments we actually also thinking of moving through. For example, we have got a digital strategy we talked about. We've got all kinds of hubs developing. We've got the VCSC discussion we had with asset mapping. We have got community diagnostics. And if the where of it was thought together, so somebody, a child with asthma, along with whatever was happening with obesity and the management of the anxiety was happening in a particular hub, and that is where we might get the biggest impact and a very holistic approach. And the second point was more about the money which John raised and others. Many of the things I saw there actually are very impactful. It's just about doing things we already do better. There is a lot of things which we know, but we just don't give it enough attention because we're just overwhelmed with what is thrown at us. So what would be useful is, before we go on to the wish list of the new innovative things, let's try to look at the things we expected to do better, because I think we'll get a lot of impact out of it. But thanks, excellent piece of work.
Just a couple of quick points from me, Neil, and then I'll let you respond. The points that you made and Ken made about connecting the more acute side of things with this very, very important. And I mean, you could look at, I don't know, people, the percentage of people who don't have their blood pressure taken versus the percentage with strokes who've got the thrombectomy to get their stroke. Very leading edge, but the two things are linked together. And I just wonder, tricky though the methodology is in situations like this, whether there are any composite measures of performance which wrap in both the preventive, traditional preventive things we've been talking about, and some of the clinical contributions into single measures so that you can track progress. Very difficult to do, but if it would really drive then integrated approaches through the way it was being measured. The second thing is, I really think we need some campaigns. We haven't got any, as far as I'm aware, never hear about them. And with some of the data you showed and I showed the other day at the management meeting, we could achieve improvements by the end of the calendar year in diabetics getting the 8 interventions, in hypertensive control, in many other things as well, maybe not the stages of cancer, but that wouldn't be impossible either to make some progress there. So it's just some thoughts from me.
So yeah, just to respond to, I mean, I'll start with your points, Liam. I couldn't agree more, and I think hopefully, if we can agree on our priority conditions, that needs to feed through to campaigns, and then on the public engagement side of things. Again, once we've got a good evidence base behind this, we've got something to go to the public with. And I agree with Rajesh. A lot of this is actually doing what we should be doing a bit better. So in respiratory health, if we had some better performance on spirometry and better education for primary care teams about evidence-based treatment, I think we could improve the outcomes, and that shouldn't cost a huge amount of money. So there are some costs in here. The back pain pathway, for instance, I think would save money. And improve availability to diagnostics to other things. So there's just some very sensible things within this that I think we could do and do better. And again, looking at the actual location of how we do this in our integrated model of care is absolutely, yes, we need to consider this. In the delivery of this, we'll be looking to use our existing work programs. But I think above that, what I would like to, and this will be part of the delivery plan, would be an oversight group, which will be clinicians and multi-professionals from across the system. That would just have that helicopter view to ensure that we are on track for delivering this piece of work, because I think the actual work of delivering them will be across lots of different work streams in the ICS.
Thanks, Neil. It's a really interesting piece of work, and I think everybody's very enthusiastic about it. So thank you. Claire, you wanted to, I guess, say something about campaigns.
Yeah, it would be great to support this work, Salim, and I think there's a real opportunity using some of the successes that we've learned through the UTI campaign. We know the more specific that we can be around messaging, the more impact we can have. The UTI campaign actually saved money. And it also saved GP appointments. So the added value that we can bring for using social marketing and using all of the algorithms we've got access to is absolutely there. I think I may just need to squeeze the man to my right for some money, initial investment to invest in some of that campaigning. But I think there's a real opportunity.
You said it'll save money. I was going to take money off you, Claire.
Okay, thank you. Moving on then to the next item. This has come on the agenda quite quickly, which I think is a good thing. We can share it with you and with the public, but essentially it arises from the events in Newcastle, Nottingham, where clinical information was not passing between hospitals and GPs, and the GPs didn't realise that the information needed to come because of an IT-related clinical communication system. So these sorts of things tend to go under the radar and you don't hear anything about them until something bad happens again. But Graham's team, helped by some of our experts, including Mike Smith, Mark Dornan, GP in Gateshead, have done a lot of work on this, and it isn't a simple a story as it first appeared. So we've asked that this comes on the agenda today. Graham's going to lead the presentation. Mike's also going to participate.
Thank you, Chairman. I think you've actually summarised my presentation, but I'll crack on. So you've already mentioned that we've got, sorry, go back over. This has been prompted, I guess, by some national events that occur both regionally and nationally, particularly where we've had largely publicised errors or omissions where clinical information has been transported from a sender to a receiver. And normally when the numbers are quite large, do we often see these in newspaper headlines. But I think it's fair to say also that there's lots of other information that fails to be received from senders to the recipients themselves, most notably discharge summaries, clinical letters, orders and test results that again fail, and each one of those presents a risk to patient safety. The challenge is to make sure that we maintain visibility and awareness of these issues, and I think bringing this to the Integrated Care Board just maintains that significance. My question would be that we need to get a similar conversation taking place in each of our provider organisations to periodically seek assurance from the people that manage those systems that the systems are working in the way they were intended, and again provide some assurance that when things go wrong, we're on top of it. As the Chairman's mentioned, we've brought in lots of subject matter expertise, and Dr. Smith to my right has particularly been working with Dr. Mark Dornan, our Chief Clinical Information Officer, to bring these issues to a real-life perspective from a GP's point of view, really understand the impact that this has on the people and population we serve, and therefore try and develop some interventions and mitigations to take these processes forward. So without further ado, we'll just hand over to Mike for the next slide or two. Thank you.
Thank you both. So the first thing we looked at was just to try and get an idea of how big a problem is this within the ICB. And to do that, we did a bit of very basic modelling just to estimate the number of data items that are transferred per year across the ICB. What we're looking at is around 15 million data items transferred between primary care, from secondary care to primary care. So that isn't just letters about patients, it's also X-ray results, blood test results, and various other miscellaneous type of things. And that works out about 5 items per person per year within the ICB, which is not surprising when you think about the number of GP appointments that we have per year, as well as hospital attendances. And based on our best estimates, we think about, of these, about 14.98 million successfully transfer. So they go from the hospital to the primary care as intended without any failure. But then there's this tiny fraction of 0.1% that fail, but it's a tiny fraction, but in absolute terms, it's a large number. And we're talking about possibly in the region of about 15,000 data items per year that aren't making the jump in the timely fashion that was intended. So they often do eventually make it when the error is detected, but that's often with a delay, and with that delay comes risk to patients. So we've thought about bearing in mind, sorry, let's just try and move the slide along there. So bearing in mind that we're around 99.9% of data items are successfully transferring, we've thought about where the problems are occurring. And one of the problems we've got is that this involves multiple organizations, multiple different hospital clinical systems, multiple different teams, multiple different specialists, multiple different transmission processes between hospital computer systems and GP systems. And trying to make changes in this environment is incredibly challenging because of both the relatively high success rate that we've already got. So to make incremental gains on a very effective system is difficult, but also because of the complexity of the system we're dealing with. And as I mentioned, the cause is multifactorial. We've got, this is just a visual to demonstrate the Swiss cheese model, which is how errors often occur in health systems, that things fall through the gaps. In this instance, the visual is in reverse. So the red arrow at the top, that's going through all the holes in the cheese is where everything's gone perfectly and the document is transferred. And the layers where the red arrow has failed to get through, the red line has failed to get through, is where it's fallen down somewhere. But where it falls down can be either due to broadly speaking, a problem with people, and that is often people are not adequately trained. So when a new system comes in, people don't know how to use the new system and therefore fail to use it properly. There's a problem with the process. So, for example, a new system is implemented and it's not clear among the people who's supposed to be the person doing the thing, and then in the end nobody does it and it fails to happen. And then it could also be a technological fault. So when a new system is put in, it's not configured correctly, and that leads to a problem. And you'll notice the common theme there is when a new system is put in. And it does tend to be that these problems tend to occur when a change happens. So if everything's running smoothly, it tends to keep running smoothly. As soon as we change something, that's when the danger point is there. Now, the real issue we've got here, and the real irony of the problem, is to try and make improvements, we have to make changes. But with those changes comes the risk of making a fault, which leads to more problems. So it is incredibly vexing and challenging to solve, but absolutely something we're up for and looking to try and make better and get that 99.9% even higher. And Graham's going to talk a little bit about some of the approaches that we're thinking about.
Thanks, Mike. And the red strapline at the bottom just illustrates the fact that the receivers often don't know there's a problem because something's been sent, but they're not expecting to receive it. So there's a concept of the loop being open. And what we need to do now is, where we can, close the loop. So the way that we do that, and if we think about some basic processes, in a traditional physical letter transmission, you would go to a post box, you would pop your letter in the post box, and you'd hope that the letter gets received at the other end. But it is a hope. What we really need to do is to actually have some certainty or guarantee. So the way we do that is we take our letter or parcel to a post office and get a registered letter, get an acknowledgement that you've sent it, and then an acknowledgement that it's been received at the other end. Now, interestingly, we do have similar systems within electronic transmission. In our basic email systems, we have the ability to receive a receipt when somebody's had the email land in their inbox. That doesn't necessarily mean that the information has been read, but there's a second stage, which would be there's a read receipt. So it's been received, it's also been read. My health warning there would be read and understood are not the same thing, but nonetheless, it would be in that inbox. And in social media, we have options now, the concept of a tick. So you get a tick when something's been sent, you get 2 ticks when it's been sent and received, and that gives the sender confirmation that that information's passed from point A to point B. So that handshake illustrates how we're closing the loop, and that's really the option that we need to try and explore. So the current priorities are, can we, where possible and appropriate, implement that 2-tick capability in the plethora of digital systems that we have within our organisations. Now, that's a big ask, and it's not likely to happen anytime soon, but raising awareness and making sure that we've got processes in place to check and balance is the first step. We also want to encourage our technology providers to build in, not add on, these types of safety nets. So whenever a new system is being procured or developed or updated, we need to encourage those providers to implement those types of solutions so we can take away some of the guesswork and hope through that process. We also want to encourage our senders to be more self-aware. So regular updates at governance meetings, board meetings, to say on a quarterly or regular basis, we've checked all our safety nets and all of our systems to make sure things are being sent and received in the way that they are designed. Ironically, many of those safety nets do exist, but on occasion they actually get switched off and not switched back on again. So there's a self-inflicted wound in many of those cases. So we need to make sure that we keep those systems and services fully operational and checked at every opportune time. We also want to try to encourage our patients or our citizens to be more involved in their health and care, and the implementation of the NHS app, and we're conscious that not everybody can, will or wants to use the app, but there will be capability within the app to receive clinical correspondence. So having the patient with that information electronically can also help when they have conversations with their general practitioners and other healthcare professionals. Whenever we identify a problem, we need to make sure that actions are followed up, and learning like this across a health and care system is a really good thing. we actually learn from errors and we can improve when we get that learning. So what we're also trying to do is to look at the use of the Boost platform as a network of collaboration, so we can actually start to share and learn across our broader system. And the final comment would be that we also want to encourage our clinical practitioners, our chief clinical information officers, our chief safety officers or clinical safety officers to be part of a network or community of interest that work together collaboratively. In the way that we've put these slides and thoughts together, it's the work that those colleagues have been undertaking that will make the biggest difference. So finally, and before we open for any questions, this is a multifactorial challenge. We've got many challenges, many systems, many problems out there, but we need a relentless focus on continuous improvement. We recognise that systems will fail for many, many reasons. The critical point is when we recognise the failure, we act in a timely manner. It's actually the time space that creates the clinical risk. So the sooner we're aware, the quicker we can act upon that. We need to make sure that those digital transmission systems are more closely coupled together. So that concept of closing the loop, we know something's been sent and we expect to receive it at the other end in a timely manner will really make that big difference. And therefore, we can start to reduce the risk of harm to the people and population we serve. Chairman, I'm happy to take any questions if that's appropriate.
Thank you very much, Graham. So open to questions and comments. Hannah.
Thank you very much for this. Just a bit of a reflection as a current patient, and in particular the kind of different apps that are available at the moment and perhaps some lack of integration between them. So, for example, for a lot of our region, there's been a move to the Badger Note system for maternity care. But what I've found is that although I log in through my NHS app, for example, the two don't actually record the same information. And so you can't cross-reference or check that what is on one system has actually been passed on to another. Okay. And for example, if blood tests are ordered by a midwife, they may appear on one app but not on the other. And so again, there's just a little bit of a disconnect. I wondered, and I know that's just examples of two apps, but I'm sure there are many others. Are there, in part of your plans, is there any inclusion of that, to try and kind of actually look at where we've got different apps that may talk to each other but may not?
Absolutely, Hannah. And I think the challenge that we have is, we could have introduced lots of these clinical portals. We'd have ended up with more portals in the submarine. So we need a single digital front door wherever we can. But the point you've made is really opportune. We need to try and integrate where possible. My sense is that this is a step in the right direction, but it's not the final destination. So where we can integrate those clinical systems, we need to understand the challenges and then work out how we bring those together technically. I don't have the absolute answer, but now that you've made me aware, I'll find out what we're doing. Thank you.
Thank you. Levi Buckley.
Thanks, Graham. Thanks, Mike. Just two quick points, really. One, which I know you talked about to the board before, is the whole inclusion-exclusion agenda. So just as Hannah says, I have a friend who accessed some results quickly through the app. I'm not sure my 78-year-old father even could do quite the same. And then secondly, I suppose, Graham, is there's still quite a lot of paper records in the system as well. So again, this is not the final endpoint, is it? There's opportunities to keep looking how we can transact information using the digital routes, but without the backup of the paper, which can just as easily go astray as a digital one at times.
Absolutely, Levi, and I would suggest that sometimes paper is a bigger weakness because quite often there's only one copy, doesn't like water, doesn't like fire, and when it's gone, it's gone. At least with digital systems, we've got backups and recovery capability, but when something goes wrong, the likelihood is it's on a bigger scale, so we just make sure that we have those safety nets and capabilities in place.
Neil O'Brien.
Yeah, absolutely support the focus on this closing the loop and that confirmation of receipt. I think that would be a really good safety feature. Would it work the other way though? Because often when I send a 2-week wait or an urgent cancer referral off, I would also like that, to know that it's got there. So is that part of the plan?
Absolutely. And we do have request and result systems, Neil, that have that handshake capability. I certainly know within organisations if a clinician requests a test there's a time stamp put on that, and if there isn't a result back in a given period, then an alert or an escalation takes place. There's no reason why we can't do that at a system level.
Sam.
Thank you, Salim. 2 questions. One, what part does the Great North Care Record play in helping us resolve this issue? And 2, out of the 15,000, which still sounds quite a lot, but obviously relatively small in the context of over 14 million separate transactions, are there any cases of moderate to severe patient harm being caused?
So the first question, Sam, in terms of the Great North Care Record, that is a capability that we should be exploiting more. And if we start to get greater integration, then the information passing between points of care should also be available within the Great North Care Record. So within a patient record context, a clinician could actually have a look at Graham Evans's last clinical correspondence rather than relying on it coming separately through a different channel. So I think that will ultimately act as a secondary measure to support that. And then obviously access to things like the NHS app for the patients themselves will close that loop. And can you just remind me of your second question? Sorry, Sam.
Any cases of moderate to severe patient harm caused?
Yeah, so for each incident that we've been made aware of over the last year or so, we've done a thorough root and branch review. And in fact, one of the bigger cases is actually just concluding its review at the moment. In some cases, there has been moderate harm, but I'm pleased to say nothing of a severe nature so far. But I would not like to say that that's ever going to be the case, because it only takes one that's wrong and then bad things can happen. But so far, so good. The quicker we can identify failures, the bigger the risk reduction we can put in place.
Just on the point of the Great North Care Record, one of their key project streams is to work on bringing the results from the various different systems into the NHS app. So the issue Hannah described, where results from a hospital clinician or from the maternity services don't feed into the NHS app. That's because at the moment the NHS app is just your GP record, really. In the future, we will be, via the Great North Care Record, integrating it all into the NHS app.
Just a quick couple of final points from me. I mean, this is a great story of improvement, and there'll be continuing improvement, but it will be a long time before the system was fail-safe. So what happens then if there's another incident against a background of very substantial improvement? How is that going to be explained? And I think it would be quite nice for us to give some thought to that, because the public will be alarmed. They'll think history is repeating itself, yet we should be able to get across evidence of what's happened and why it's impossible to get to zero risk in many, many systems. So just something worth thinking about. And I suppose the other thing would be if something does start to go wrong at a system level, can it be spotted earlier, so that you can interrupt the trajectory of harm which would come if it wasn't spotted?
If I could just respond on that last point, Liam. So I think part of that is the regular reviews. So within organisations, don't wait until something goes wrong. Have a regular checkpoint quarterly to make sure that things are working as designed.
Thank you very much indeed for that, both of you, and I know a lot of other people have been involved as well, so thanks to them as well. We're moving on now to Martha's Rule. I'll just briefly say I was involved in the national work in this field, and on the panel, you may remember from our board development event on patient safety, one of the videos shown was an interview with Mary Oper Mills, who's a journalist and whose daughter died due to a deterioration in her care being unrecognised by the clinical team. And she's called for a mandatory second opinion. It was then investigated further on behalf of the Secretary of State by the Patient Safety Commissioner, Henrietta Hughes, who got a group together, including me, or several groups, and then wrote a letter to the Secretary of State proposing a way forward. But as David, I'm sure, will tell you, this has got a lot to do with the quality and structuring of in-house escalation teams that can respond very rapidly. It's also got a lot to do with deep-seated cultural difficulties in listening to what parents and patients say and actually taking account of it in your decision making. But over to you, David.
Thank you, Chair. So the first phase of the introduction of Martha's Rule will be implemented in the NHS from April 24. So once fully implemented, patients, families, carers and staff will have the round-the-clock access to a rapid review from a separate care team if they're worried about a person's condition. So as Liam said, Martha Mills was 13 when she tragically died in 2021 after developing sepsis in hospital, where she'd been admitted with a pancreatic injury after falling from her bike. Martha's family's concerns about her deteriorating condition were not responded to promptly, and when she challenged both consultant and nursing colleagues, her cries for help were ignored. And in 2023, a coroner ruled that Martha would probably have survived had she been moved to intensive care earlier. Martha's parents have campaigned since their daughter's death for the introduction of Martha's Rule, which is modelled after Ryan's Rule, a similar system introduced in Australia. So in response to this and other cases related to the management of deterioration, the Secretary of State for Health and Social Care and NHS England committed to implement Martha's Rule to ensure the vitally important concerns of the parent, patient and those who know the patient best are listened to and acted upon. So there are three components of Martha's Rule. So all staff in NHS trusts must have 24-hour, 7 days a week access to a rapid review from a critical care outreach team who they can contact should they have concern about a patient. So that's anybody can contact that team, whether it be a family member, whether it be the patient themselves or any member of staff. So all patients, their families, carers and advocates must also have access to the same 24/7 rapid review from a critical care outreach team, which they can contact via mechanisms advertised around the hospital and more widely if they're worried about the patient's condition. So that element is actually Martha's Rule. And then the NHS must implement a structured approach to obtain information relating to a patient's condition directly from patients and their families, at least daily. In the first instance, this will cover all inpatients and acute and specialist trusts. So that will be a massive change to how we document a patient's care by ensuring that actually the patient or the relative have documented evidence in the notes on a daily basis. So the implementation of Martha's Rule in the NHS will be a phased approach, beginning with at least 100 adult and paediatric acute provider sites who already offer a 24/7 critical care outreach capability. So the NHS have asked trusts for expressions of interest to be part of the first phase of the programme, and there are 5 specific questions that they must answer, but they must immediately have 24/7 critical care outreach. So the first phase will take place during 24-25 and will focus on supporting participating provider sites to devise and agree a standardised approach to all 3 elements of Martha's Rule, ahead of scaling up the remaining sites in England in the following years. So the focused approach of the initial provider sites will inform the development of a wider national policy proposals for Martha's Rule that can be expanded in a phased way across the NHS from 25-26. And it will also identify ways to roll out an adapted Martha's Rule model across the settings, including community, mental health hospitals, and where the processes may not apply in the same way. So the introduction of Martha's Rule comes alongside other measures to improve the identification of deterioration, including the rollout last November of the paediatric early warning score, which is built on similar systems already in place for adult, newborn and maternity services. So to ensure that Martha's Rule is as effective as it can be, it will be implemented as part of an integrated programme to improve the management of deterioration using the PEER framework, which helps systems to prevent, identify, escalate and respond to physical deterioration. This work will improve how the NHS supports staff to manage deterioration and encourage greater involvement from patients, families and carers. So Martha's role applies primarily to acute and specialist trusts, and we've requested that all our trusts in the region look at how they review the rule to apply to their own organisations. So there is variation across the trusts as to their readiness to adopt Martha's rule. So 4 trusts have call for concern in place. So call for concern provides a structured approach to deteriorating patients, and they are in North Tees, South Tees, South Tyneside and Sunderland, and County Durham and Darlington. So the concept of call for concern was inspired by the University of Pittsburgh Medical Centre in 2005, and it's structured to a similar service after the case of Josie King, an 18-month-old child who was an unavoidable death in 2001. Call for care was then later implemented by the Royal Berkshire National Health Service Trust in 2010 due to ongoing deterioration in patients and failure to rescue instances. So call for concern service is important as an additional safeguard to prevent patient deterioration. The service is valuable in promoting patient safety, improving healthcare professionals' practice through education and improving the patient journey. So all of our trusts have a plan in place to meet the requirements, and County Durham and Darlington has been an early adopter and has the support 24/7 in place currently. So the ICB will monitor the plans for all providers to meet the requirements of Martha's rule.
So just to be clear, is there any sense in which our services are being held back in implementing this by national orchestration?
So generally this will be kind of, so the 5 questions are very specific in terms of when, if not already, will Martha's will be adopted by the trust? How does the trust propose that this option will be communicated to patients and their families? So kind of you walk around kind of the 4 sites of call for concern, there's lots of posters everywhere which says this is the number, this is who you contact. There's elements around the trust recording such events for the purpose of audit and CQC's inspection, and then what difficulties are envisioned to ensure out of hours availability of a senior clinician for a second opinion. So I think it's that element which is the stuffing block, is out of hours second opinion, and this is around additional funding to ensure that the developments can take place.
Okay. The key thing in resource terms and capacity, I mean, Ken will correct me if I'm wrong, is that whether you have a rapid response team there, which can then be tuned into this new arrangement. But obviously, if you haven't got one at all and have to set it up, that would take a bit longer. But the other things, really, the recording of data, and you can start that up as you go along. Wouldn't you think so, Sam?
Yeah, I think most people, everybody has a plan. The element of it is the out of hours, it's the 24/7. So all places have got a critical care outreach team. Not all of them are 24/7.
I mean, I would absolutely agree with you, Chair, and I think that whilst trusts will be working to, if they haven't got that in place at the moment, clearly it will need to be put in place or arrangements sought. The other areas are more cultural change, systems and processes, and there'd be no reason why any of our trusts couldn't work to establish those.
Okay, and Rajesh, I think you're going to tell us how difficult this will be in mental health field. I'm sure it will be.
No, thanks. No, I wasn't going to ask about mental health. It was just a question, David, was about, based on the incidents we know of now and triangulation and so on, do you know which of our hospital trusts might be in need of this law more than others?
So from the data that we've got, we can identify, but I do think there's 2 things that are common for us from a patient safety perspective. One is the sepsis, in terms of early identification of sepsis and putting in the process in place early. So this was a sequin a number of years ago that should have been adapted, and what we have found is that kind of when the funding isn't there, additional funding, the audit doesn't take place as well as it should. So this is one area that we're going to work on, and the other is the identification of deteriorating patients. So they are 2 things that we know are problematic throughout any of our organisations.
It is assumed that most of this is sepsis, but the causes of acute deterioration are a lot of them really, and including things like opiates, all sorts of things which you need to take account of. So the generic way of looking at it is actually very effective, I think, if you could get there. Other comments, questions? Oh, Mike, yes, sorry.
Thanks. I think as far as the structure is concerned, the process, it seems very logical and very welcome. I think one of the worries I have about it, and perhaps a bit of skepticism, is we've heard time and again at this board of events where in hospital trusts where things have gone wrong, and it's often due to a culture, and it's a culture that doesn't permit disagreement within teams. So the teams all work in one very strong mindset, and they don't really disagree with each other. And therefore, I worry whether a second opinion will be that valuable. And if it was one of those teams, in all likelihood, they would not disagree with their colleagues, and therefore not really add any value, which would be a real loss of opportunity. How can we make sure that we don't put the process in place, but don't have the culture to make it actually valid in the end?
No, that's a really valid point, Mike. And I think if you have the chance to hear Rupi or Paul speak around their experience, it's really harrowing in terms of what they had their experience. So I think there's two things for me. One is actually this is an independent review, and actually you should be able to call for a second opinion. So it's really clear that it's a kind of direct, and you can do that yourself, which is very different to kind of asking for a second opinion. So it should go through a different mechanism rather than saying I don't agree with that. So it's an escalation point. So I think we need to look at actually the culture when we're implementing these processes. And the second bit around culture is really important about professional deference. And actually there were some elements in this case where obviously, and she's quite vocal in terms of the nursing team didn't raise concerns due to kind of what the culture was. So there's a really important piece around professional deference that we need to look at.
Any other comments on this anyone wants to make? Well, thank you, and we look forward to being in the forefront of implementation. Thank you. Questions from the public related to the agenda, Claire?
I can confirm, Chair, that we do not have any questions from the public relating to the agenda. However, we have received 2 questions relating to physician associates and how many are employed in our region, and how we are adopting the BMA standards. We will put a response on our website.
Okay, thank you very much indeed. Is there any other business from anybody? If not, can I thank you for a long but fulfilling meeting, and look forward to seeing you next time. Just confirm when we're off the air, Lee.